I'm
So I
I
think we need a backup just in case.
yeah, please, of course. But I I had sent you all the recordings of all our meetings so far. Okay. And so I don't know how, I listened to a little bit. I don't know how. I think it's you can almost just play it and then just kind of listen when you're stuck in traffic or something like that, maybe, or when you need to go to sleep, something like that. Okay. So today we're gonna start talking about vertical dimension. I wanna, and I've been kind of delving in and out of this a lot, but I think, in my humble opinion, I think one of the main reason why so many dentists get lost in occlusion is because they don't get this vertical dimension idea. Okay. And so, and once you get it, it's not a big deal. It's just that even the chapter, I was rereading it again last night, and I think there is just a lot of, I I guess, the best way to talk about it in modern language in America is lots of chatter, just too much side noise that's going on, and they don't really get to it. And I think in order for you to appreciate, like the when you finally get home, you do have to go through the chatter, so that when you go and listen to some other people's lectures, that you don't you don't think that is something that's like some sort of a novel idea, novel idea. Okay. Um, so um, um, so on the first page of chapter 13, on that little, so it's technically page 113, he says, principle, the repetitive contracted length of the elevator muscle determines the vertical dimension of occlusion. And and as much as I think sometimes um, Dawson inadvertently mislead us or confuse us by trying to address so many different things, this principle is actually very much true, and that is contracted length of the elevator muscles determines the vertical dimension of occlusion. Okay, so it's all about the muscles. I want to emphasize that it's all about the muscles. You know, I know I tend to repeat things over and over, but I just cannot emphasize this. And then so we come to the point, like, okay, so we're kind of cheating. We have the conclusion first before us. It's all about the muscle. And what do? We get in there and we talk about pretty much everything but muscle until the towards the end. I mean, when we talk about the muscle, it's more about muscle as it relates to the bite. And so, what I want to talk about is this. I want you to keep in mind vertical dimension of occlusion. When was it first introduced to you as a dentist or as a dental student? When you were learning to do denture, right? When you started to do denture, is when we talk about vertical dimension of occlusion. Okay. And the important thing to know is that whether it's somebody with teeth or without teeth, vertical dimension of occlusion is always there. That notion, that concept, that aspect of one's biological being is always there, whether there is teeth or not. Okay, so it's really best if you understand it without teeth first. Remember, after all, we've spent all this time talking about occlusion, understanding occlusion, and if you think about it, we hardly talked about teeth. Maybe we'll get to it today, okay? We hardly talked about teeth. We're setting up the stage, really. We talked about the bones, we talked about the joints, okay? And now we are talking about the muscles, okay? Today is vertical dimension, neutral zone, range of motion, okay? Things like that, okay? Envelope of function, rather, okay? That's the word that we use, okay? It's all about the muscles. I just cannot emphasize enough. Okay. And I think we actually sort of I actually sort of got to it before we wrapped up last time. You know, forgive me for going back and forth, but page 129, right? You know, page 129, Dawson quotes another medical doctor, I'm assuming an orthopedic doctor, that says, "When bone and muscle war, muscle never loses. And when teeth and muscle war, muscle never loses." You have to remember that. So when teeth are breaking down, it's because there is conflict between where the teeth are and where the muscles are. Muscle is the ultimate living biological aspect that we have to deal with because if you think about it, teeth don't really move. They break down, they move a little bit, but not in an immediate sense. Bone remodels, but same thing, almost as like teeth. It doesn't really move per se. I mean, like not to the degree of muscle. No, nothing with the joint. There is nothing out there that is as dynamic as the muscle. It is the muscle that we have to just drill it into our head. Okay, that's what we have to understand. Okay, all right. So now, um, you know, page 114, he talks about understanding vertical dimension, and then he says there are four serious misconceptions. Okay, okay. Now you need to know that number one, you cannot determine vertical dimension based on whether the patient is comfortable. Mm, I would, in essence, agree with this statement. Patient cannot be uncomfortable. Okay, but just because somebody is comfortable does not mean that you got the vertical dimension correct. Now, I personally feel that it's a little bit of a how should I put it, uh, wrong notion, because the example that he gives, and in fact, just about I'm sure every dental school faculty, if they ever talk to you about vertical dimension with people with teeth, I'm sure they had talked to you, okay, about patient with splint therapy, you know. So the conventional wisdom, even when I was in pros, and even now, I'm sure in pros programs, they'll say, well, if you want to raise somebody's bite, you got to put them in splint therapy, and if they are comfortable with that thickness, that means we can raise up to that point, or something to that effect. Well, you know, one's ability to tolerate splint height is not the same thing as your ability to tolerate the teeth height to that splint height. Okay, there is two clearly different. That's two different dimensions. Okay, so 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 I think it's yeah, you need to be comfortable, but just because somebody is uncomfortable doesn't mean that, and if somebody is just because somebody is comfortable also does not mean that is the vertical dimension. If somebody wants to tell me that, you know what, somebody can tolerate splint therapy of certain thickness, I'm gonna reduce a certain amount from that to get the vertical dimension. Theoretically, I can go along with that, but the vertical dimension of splint cannot be taken as the vertical dimension of occlusion. Okay? That's number one. Number two, measuring the freeway space is not an accurate way to determine the correct vertical dimension of occlusion. So VD, vertical dimension at rest, minus vertical dimension of occlusion, you know, the freeway space, okay? And I'd have to sort of agree with that also, although it is an important concept, just like what we just said about splint, and then you subtract certain distance, dimension to get to the vertical dimension. Um, and we can say that some aspect of that is freeway space. The reason is because there is really, if you think about it, there is really no good way to determine how much freeway space is adequate. That's why that statement, it has some teeth to it. Okay, so so yes, measuring freeway space is not accurate to get to the vertical dimension, but there needs to be a certain amount of freeway space, okay, for somebody to have. So vertical dimension. Let's put it this way: vertical dimension of rest cannot be less dimension than vertical dimension of occlusion, right? Does that make sense to you? Okay. So yes, that's an important concept, but again, there is no like formula we can come up with. Okay. Number three, determining the rest position of the mandible is not a key to determining vertical dimension. You know, I'm gonna say that that's I would agree with that. The reason why he's saying that and he talks about neuromuscular dentistry is because depending on where you are at in the country and what kind of CE courses that you take, lately they've been kind of really quiet. But there is, I think I have mentioned to you many times, there is an entity called Las Vegas Institute, LVI, and very fancy. They really kind of um, took advantage of Las Vegas being a lot of people's destination to get away from their practice, and they built a beautiful facility to do that. And then they branded themselves as neuromuscular dentistry. And what they were doing was that they would put bunch of electromyography sensors on your masseter, temporalis, masseter, and then I think even pterygoid. And then what they would try to do was to find the jaw posture where there was least amount of muscle activity. And they decided that is where we need to be at for the CR. That's my understanding. And then they would kind of come to that also the VDO, vertical dimension of occlusion idea from that. But the funny thing is that every time I would see those people who were treated by them and they were having problem, it's almost always they were open too much. So it's almost like they took vertical dimension at rest or something close to that as the vertical dimension of occlusion. Okay. Because if you think about it, vertical dimension at rest would be closer to, right, closer to where the muscles are least active, right? You know, so 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 I know that Dawson is very much aware of trying to get rid of these fallacies in dentistry. Um, so at least that's why he's saying that. Number four, lost vertical dimension is not a cause for temporomandibular disorder, and I would agree with that. To a certain range, to a certain range. Okay. Um, I have seen some patients who are uncomfortable going to sleep without their dentures. Not for psychological reasons, not because they didn't want to wake up and see their husband or wife without their teeth. It wasn't that. But when they take the teeth out, they found themselves over closing. Think of it like this. They're still clinching without teeth. So if you accept the notion that people were um, the people's clenching habit or clenching condition is centrally mediated from the brain, okay, then they would be doing that even without teeth, right? Now, if the muscles are contracting without teeth, what can happen is your socket here is over rotated, so to speak. And as they're doing that, the socket almost feels like it's getting pulled out. Okay. So I've had some patients where they were genuinely uncomfortable or in pain with the TMJ, okay, and the muscles when their teeth were not in their mouth. And then, so then we had to tell them, okay, you can wear your denture to sleep, but we still need a few hours a day for your gums to be able to breathe. Okay. So, so yes, all these things, I mean, broadly speaking, I would agree with that. Okay. Now, that because Dawson spent some time about eruptive force and how he relies on uh, natural process of eruption to establish vertical dimension. I have to sort of address that, okay? Um, um, and that is, so take a look at figure 13-1. And those of you who had treatment plan with me on some cases, you know that I talk about this a lot, how typically lower anterior segments, incisors, or even including canines, you can tell they have over erupted. Some people will call it altered passive eruption. Some people will call it super eruption, or I call it just over eruption. Okay, and 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 he's saying it's because there is no contact with the opposing. Okay, now let's take a look at his figure 12-2. It says the eruptive process continues until the lower incisors contact the palatal tissue. Um, there is one thing that I think he overlooks in here, and that is if even in that drawing there, the drawing he's showing, his lower incisor is touching the upper incisor in the lateral contact portion, which is exactly what we see in our natural teeth situations. Okay, so what I wanted to say here is, and I want to really hopefully that you can understand, and that is lower teeth continue to be stimulated to be erupted if they are touching the upper front teeth sideways, just like that picture 13-2. Okay, and and then you might say, well, why do not all the people erupt like that? Okay, and I'm gonna have to say, gee, I wish I knew everything. I don't, but I will say this: that the people who's who eventually develop a lot of deep bites, where people get older and they just become deep bites, they maintain lateral contact. And I think a lot of times we sort of half get it. So those people who get deep bites, we call them what? We call them class 2 division 2. So remember, I know that it's poorly defined, but remember how I tell you that to me, class 2 cases are all those patients who have, shall we say, a lot of mandibular movement. To me, I think if we just develop, combination of teeth alignment and muscle movement, a jaw movement, as how we define our classification of occlusion. To me, I think that would be more helpful rather than Engel's classification. Okay. So if people are touching like this sideways and they have a lot of anterior posterior movement, so they are touching and to a certain extent get to that sweet spot of stimulating PDL, okay? And then they have good bone, shall we say, bone, strong bone. So they're not really getting too much mobility on it. I think the PDLs get stimulated to the point where they just continue to get erupted. And that's why these people, when they get to be in their like 40s, 50s, and 60s, the deep bite really becomes a problem, because the mandible keeps on wanting to move sideways and it was never calibrated correctly. Okay. The notion that they will stop when they touch the palate, I think is, I don't know, to be honest with you. I've seen people where their palatal contact, soft tissue contact did not stop the teeth. They literally keep digging into the gum tissue to the point where now they're getting perio problems. They literally have the palatal aspect of number 8 and 9, 7, 8, 9, 10. The lower incisor is digging into the gum tissue. They are literally getting mechanical recession. So just to say that the teeth are gonna be stopped when they touch soft tissue, I think that's an overstatement. To me, I think probably what more likely happens is once it gets to be that bad, subconsciously, patients don't move their jaw as much. They are trying to protect themselves. So there is not as much of stimulation to continue to erupt. But if those some people are not able to, psychologically, their neurology doesn't really stop from doing them, then they keep on doing it, and those are the people you start seeing gum tissue starting to dig in there. Class 2 division 2, these types of examples, where class figure 13-1, 13-2, to be honest with you, they present the biggest challenge in occlusion, in my opinion, because I sort of have the answer, but it's just that it's really hard to implement it to the patient. Because imagine if somebody came to you with figure 13-2 type of scenario, where they are hiding, their lower incisor teeth are not showing at all. I think they, I think there are some pictures of that I remember when I was reviewing this. Let me see if I can find the best example of that. Um, Page 134, okay, figure 14-9. If you look at that, okay, no, the bottom picture, that patient has 100% overbite. Okay. You know, how do we fix that? It's not so easy. Meaning, just from the aesthetic aspect of it, we can go ahead and do crown lengthening and da 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 da. No, but that does not fundamentally address the etiology of it. So if we get the etiology wrong, then we're not gonna get it correct. So if we think the etiology is because they weren't touching the tongue, um, or the teeth, because I think what Dawson is saying, and we're gonna go back and forth, back and forth. Okay. One thing that I want you to just let me see, because these are all related issue. Okay. Page 162. 162. If you take a look at the picture on the lower picture, bottom picture, he's saying that's the ideal contact schematic between upper and lower. Okay. And he's saying, Dawson himself, next page, 163, he says unstable contact. And then he's talking about how the incisor edges are touching sideways, or the lingual contour of the upper and lower incisal facial contour. But one thing that Dawson does not talk about, okay, he he just presumes, and the readers presume that this unstable contact is occurring when we are chewing. And obviously they do, but what they don't talk about is when that unstable contact is occurring in the phonetics. And what I'm saying is that is enough to throw off the balance. I don't have any problem with Dawson saying the drawing on 162 is the ideal contact. Even though if I were gonna really say that, I could actually challenge. Well, what angle, what degree of angulation is that incisal contact supposed to be? Do we want them? Obviously, he didn't draw it as horizontal. At what angle does that become a problem? Where does that become something like drawing on 163? What angle? He does not address that. Okay. So if you don't go into that detail, all these things don't really mean much. And that's exactly why people get lost. Okay. So he's talking about anterior guidance in page 162, 163. We're going to get there. Okay. But before we get there, we need to be able to answer. Okay. What is the difference between those two? I'm going to say, by and large, it's the jaw movement. It's the jaw movement. It's the muscle. So if you get so engrossed into just the teeth part, then you get lost. Now, what are the people who get engrossed in teeth part and just the shape of the teeth? They are the cosmetically oriented dentists. Because to them, teeth have to look certain way first. Instead of trying to make teeth fit certain criteria in a physiological sense, in part of the total picture, they start out with saying, I want my teeth to look like this first. And that's where the problem comes in. So I want you to always challenge yourself thinking, it's the muscles. It's the muscles. We have to understand the muscles. Okay. Now let's go back now to page 115 again. Okay. Okay. So let's go back to the page 115 now. Okay. Okay. Well, actually, you know what? Let's go back to 114 again because I think it's worthwhile for me to address that. The little box there in 114 on the right-hand column. He says, because this part is coming up right after he's saying, the vertical dimension, loss of vertical dimension does not cause TMJ. Okay. The big question, if altering the video does not cause discomfort and does not cause TMDs, why should we even be concerned about the video? Okay. Answer. We should be concerned because failure to understand the physiology and biomechanics of vertical dimension has led to inappropriate overtreatment, has resulted in iatrogenic damage to dentitions and misdiagnosis of TMD. And because failure to understand the true nature of vertical dimension affects a major amount of the decisions every dentist must make in practice. And I agree with that statement. The only problem is the details as to why we're saying that is the problem. In my opinion, okay, so let's go back. Let's go to the page 115. Take a look at how he's saying raising bite, blah blah blah, especially with the splint. You start with the first drawing and you go down and you sort of unload the unloading of the TMD, TMJ, and then he's like saying it adds to the it results in shall we say intrusion of those teeth. Now, it's rare that you're going to have that much of a dramatic effect. Okay. However, I will say this. Many of you who've treatment planned with me understand how I emphasize lack of posterior support. Lack of posterior support. The reality is this. We measure vertical dimension, let's say in millimeters or whatever, okay? But we don't actually, if you think about it, we don't get to measure vertical dimension. What we measure is changes in vertical dimension, if you think about it, right? We don't have an exam sheet that says, John Doe's vertical dimension, 50 millimeters. No, we don't say that. We say somebody has either adequate vertical dimension, and I'm going to add or subtract. Okay? Now, when I say if somebody has lack of posterior support, it could be very, very subtle, right? It could be, let's make it easy. Let's say half a millimeter. And that the anterior teeth have to flare out like this in order for the back teeth to start contacting. Now, if you want to describe addition of that half millimeter in the back so that the front teeth don't have to have the fremitus as saying we need to increase the vertical dimension, you know, you know, make yourself happy. Go ahead. Okay. I'm going to say, no, I'm not really meaningfully altering that person's vertical dimension, right? I'm just restoring posterior support. Okay. But here's the thing. I want you to, that this is going back and forth, back and forth. So remember what I always used to tell you. If somebody has lack of posterior support and they're touching in the front too much, and then if they're clenching, remember what I said, that when they bite down all the time, that they tend to, the best way that I can describe it is that they tend to compress their TMJ, the joint, the disc. So if you use splint therapy or if you open up their bite or increase their posterior teeth dimension so that the back teeth are now more meaningfully touching, well, the disc will not be compressed as much. And remember, that's why I say then the jaw rotates a little bit because the condyle sort of comes down. And Dawson is describing that whole process here as saying that these people are unloading the joint. Okay. But you don't have to increase the vertical dimension by 2, 3, 4, 5 millimeters in order for that process to happen. And if they are happening, it's because they were too compressed to begin with. Okay. So we cannot really talk about vertical dimension without understanding what it means to have lack of posterior support. To me, that is the biggest, one of the biggest problems that most dentists do not appreciate how widespread lack of posterior dentition problem is. And guess what? They go hand in hand with premature contact with the front, just like the drawings of figure 13-2. Okay? And I hope I'm not confusing you too much by going back and forth, back and forth. But if somebody was to only talk about vertical dimension, I don't know how you felt. I've freaking, frankly read this chapter, I don't know, 5, 6 times, 7 times, whatever. All it does is confuses the hell out of you until until I get to page 127. He talks about establishing video when there are no opposing teeth, and he talks about closest speaking space. And I'm like, why the hell do you have to wait until the end to talk about this? And if this concept works when you're missing teeth and when you're adding teeth, why don't we apply this when we are talking about teeth? Somebody who has teeth. To me, that is the biggest blunder or the oversight of Dawson's book. If he were just to talk about the closest speaking space, and you know that every time he throws this in the chapters, I bring it up to your attention. This is not the first time he's talking about the value of phonetic testing, closest speaking space. So I have to assume this is almost like their little secret. Like they don't really wanna make a public announcement. It's almost like, it's like they whisper it to you. This is really the most important thing. The rest of it is just to confuse everybody. Okay? I almost feel like, it is just such a waste of time to talk about rest of the stuff because all it does is just confuses the hell out of you because there is no real solid thing you can bite on and chew and get the juices out of with all the other stuff that he's talking about. He talks about muscle getting elongated. He talks about, even freaking doing a muscle elongation surgical procedure. You know, talks about teeth getting intruded. All these things. Okay. At the end, if the and I agree, if the vertical dimension, if somebody was to be opened up too much, there will be attempt for the body to try to compensate for it by contracting and there will be some intrusion. But has it ever occurred to you that maybe then the people we think are centrally mediated to clinch, maybe those people were born with vertical dimension that was too tall. There is a mismatch between the muscle length and the teeth height. Maybe that's why they keep clenching. If we experimentally increase somebody's vertical dimension beyond their tolerance level, we know that they become clinchers no matter what because the muscles want to go back to their resting position. They're stretched. They want to go back. It's not comfortable. If I walked around, I know that you can sort of see my camera. If I walked around with my muscle, but with my arms extended out like this every day, how long can I maintain it like this? No. I'm going to want my arm to be here. I don't want my arm to be like this either. This is over closed. This is open too much. Right? My sweet spot is somewhere around here. So there is sweet spot for the muscles. And that's the range of motion. That's the envelope of motion. One can even say that's, it certainly has something to do with neutral zone. So we need to understand that. Now, how do we best understand it? Through observation, we come to the conclusion that it is phonetic testing that gives us the best ability to observe that. Now, it doesn't mean that I do 30 minutes of phonetic testing with my patients. Of course not. As you know, those of you who have done it, phonetic testing is deceptively too simple. Once you understand and once you start doing it, right, you realize it can't be this simple. And I go, yeah. It's almost as if all these big names, they don't want to tell you the simplest thing. So they have to complicate everything. Okay? So if somebody, to me, if somebody is at a optimal vertical dimension, okay, then then everything will just kind of flow through them. Okay. Now he talks about a lot about, but that it is important. I do believe that it is helpful for you to read through and understand that vertical dimension. For example, picture in 118, vertical dimension can be, one can have same vertical dimension. If person A has long teeth, short bone. Person B has short teeth, long bone, right? But what if person C has long bone, long teeth? That person, not through none of his fault or her fault, is stuck with vertical dimension that's too big. That's why some of you have heard me tell the patients, jokingly say, you know, God was a little too busy when you were being born and when you were growing up. You know, there's a mismatch between your jaw size and your teeth size. I tell them, your body frame is a small frame and your muscles are small bodied muscle, but somehow God forgot and gave you extra large teeth. There's not enough space. They get all crooked. Then the orthodontist pulls the teeth to make it nice and look even. While they're doing that, they bring the teeth back in. They violate your envelope, what you might call a neutral zone. They violate your range of motion. If you understand that they can violate neutral zone and range of motion, the same concept vertically, that would be the vertical dimension. Okay. So we need to understand how biologically that there is this sort of flow to this overall things to how they are going to be played out in. Okay. Okay. So let's go back to see if we can make some sense out of what Dawson was saying. Page 119. Okay. Let's see if we can follow through when he says rules for determining the video on patients with teeth. The video that requires the least amount of dentistry to satisfy aesthetic and functional goal is always the video of choice. Okay? I don't have any beef with that statement. Number two, maximal intercuspation of the posterior teeth determines the existing video. Okay, we know that. The muscle-determined video must be measured from origin to insertion of the elevator muscles. Well, so this is a problem, you know. I mean, like, really, we're gonna go through the trouble of measuring actual muscle length. Are we proposing that we're gonna do a anatomical dissection? Come on, give me a break, right? To me, that kind of statement is what throws off people, right? Okay. Number four, position of the condyles during maximal innercuspation must be considered when evaluating video. Okay. Well, hopefully we agree that's close to CR. Okay. Number five, if the video must be changed, it should be determined at the point of anterior teeth contact. Well, I don't know if it should be determined there, but it's easy to measure there. Okay. It's easy to measure there. Okay. Whether it's measured in the front or back, vertical dimension, it should be, basically it's the same mandible that's moving. Okay. Number six, changing the video by either increasing or decreasing is tolerated well by patients and within reason, causes no harm to teeth or supporting structures. Okay, well, if the patient can tolerate it, of course, right. Changes in the true video are not permanent. The video will return to its original dimension measurable at the masseter muscle. Again, I think, you know, it's not permanent. So they're saying if you open somebody up, they're going to go back to whatever. And I'm going to say within reason, I don't have, I can see in some situations that's going to be true. Because if you open somebody too much, you do a rehab, guess what happens? Patients break up all their teeth, break, as they get back to the muscle length that's out here. If you force somebody's teeth to be out there, they're going to want to come back here. Okay. So this is the problem. That is, rules for determining the VDO on patients with teeth do not mention phonetic testing. This is the problem. Why do we use that only for people who don't have teeth? You know? So I just want you to feel comfortable, okay? Deviating from what Dawson said. Or let me just put it this way. What Dawson said is not holy scripture. Okay? And I'm sure he will agree with this. My humble criticism. Okay? So I do agree that the term bite raising, I don't like that term. I mean I can tell you um so when I so I think it was about 6 years, 7 years after I finished my pros that I spent 6 years at UCLA, first round of teaching, and then when I left UCLA, went into private practice. I One of the practices that I purchased was one of those old-fashioned ethology TMJ guys, and indeed he he increased people's video a lot. I saw that. And that was my first time actually seeing that done in private practice routinely. And I have to say, my goodness, this is interesting, I said. Okay. And then when I saw the patients who were being followed up in his office, he was not interested in following up those people. He was forced to follow up because so many of them had, guess what? Breakdowns on their restorations. And as the young doctor going into that practice, and as I was taking over the practice, I had to try to figure out how to manage these people. And invariably, the only way that was left for me was to reduce their video, go back to closer to their original video. Now, none of them I had to go back to the original video. Okay. that many of them became stabilized after I reduced a certain amount and calibrated their occlusion. And so the conclusion that I came to at the time was they were just simply open too much. Okay. Why? Because there was no phonetic testing. The guy had no idea how to do phonetic testing. What they did was they mounted a cast on an articulator and they just hand opened it. This looks about right. Okay. Kind of like what Dawson was doing when he's doing functional smile design. Okay. You know, he has that case where they mount case on an articulator. What do they do? They do initial equilibration on the cast. They kind of open up the cast and this looks like we can make good looking teeth. In a page, if you go to page 153, you know, and he goes through the process of how he does diagnostic wax up and how to make things look good and da 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 da. Okay, functional smile design. Okay, there is no reason or rhyme to how much they wanted to open. They just said, that looks good. That's the problem. How many times have you heard that from your dental school faculty? A lot, right? Yeah. So instead of saying that, I mean, you could say that because at the end, I honestly, we do want our teeth to look good. But as much as you're doing that, you need to have something that guides you if that is going to be too much. And that is what? Muscle, muscle, muscle. How are we going to, this idea about measuring like masseter length? Oh, give me a freaking break, right? Come on, right? That's why people get confused. You read this stupid book and people can't make logic out of it. I'm sorry. I don't mean to be so offending. Okay. Okay. But I'm just trying to make a point. I'm just trying to make a point. Okay. There's reason. There's a good reason why so many people get lost. Okay. So what needs to happen is all these things, all the rationale that he tells you, okay, okay, um, um, tells you needs to be in how should I put it in harmony with the phonetic testing. So let's take a look at the picture of the case in 124, the patient, the poor guy or patient. And those of you who have, I'm sure you've had patients in your practice by now who could come in with teeth like this and you do phonetic testing and there's no space. I've had people like that. Okay. Now, the interesting thing is this. Interesting thing is this. Because video and range of motion, neutral zone, all that thing is muscle mediated. And muscles, as we know by now, can have slightly different size to it. What I'm trying to say is this, that you know how you can get muscle that's all knotted up. Okay. So one's phonetic testing, because it's muscle is dependent on muscle. Once you deprogram somebody, oftentimes their phonetic testing will change. Not a lot, but it can change. So there are people that I swear I couldn't tell if they had any phonetic interference. But let's say once I put them through my splint night guard deprogrammer regimen, and once they become comfortable, okay, with their jaw, the muscles, everything, and guess what? All of a sudden, their phonetic interference shows up. I've seen that countless times. In the same manner, somebody's video can be locked closed because of years of clenching. Their muscles are just tightened up like this all the time. Okay? Once you get to have them relax the muscles, deprogram them, guess what? They can start to become slightly, um, shall we say, um, more space will open up. It's kind of like this. When you see some people who are like really, really heavy clinchers, grinders, when you look at them, they almost look as if like you have these Olympic weightlifters, bodybuilders. I don't know. To me, every time I look at those bodybuilders and weightlifters, I kind of feel bad because because when their muscles are that big and that pumped up, guess what? From my perspective, they don't look that comfortable, right? The muscles are hypertrophied, right? In fact, when those bodybuilders go out before they perform, right? They want to pump up their muscles, okay? So when the muscles are tense, when the muscles are pumped up because the patients have spent 24 hours a day, 7 days a week, clenching all the time, okay? That could alter how your muscles move your jaw, okay? So so you have to always remember muscles do need to be somewhat deprogrammed in order for you to get to the true sort of dimension of them. And that's one way that I try to tell my patients. I don't know, I maybe some of you might want to tell me this, because sometimes I think my examples, analogies are not the best. But I tell everybody, I tell everybody, look, I don't want you to eat a lot of hard food. And they go, why not? Because I don't want you to overwork your muscles too much, your jawbone too much. Okay. And I tell everybody, you know, you know, what we want, you don't want Arnold Schwarzenegger body. I'm sorry. Okay. In the peak of him, right? When he was like a bodybuilder. Okay. All right. What you want, what's actually a healthy body is Bruce Lee body. If some of you are too young to know, Google Bruce Lee body, okay? Arnold Schwarzenegger body, okay? Yeah. Arnold Schwarzenegger, anybody knows, yeah, he's drugged up. That's all hormone. Yeah, just too much, okay? What you want is fluidity. In fact, I'm not saying this just because I share the same last name as Bruce Lee, but ha ha ha. But he sort of like subscribed to certain Asian Chinese philosophy, and that is, we need to be able to react to things as if you're like water. You don't want to be too harsh force. You want to be able to literally be fluid in order to deal with it. And I think when if somebody works with their hand too much, right, then you get calloused here a lot, right? Your things become hardened. Same thing with the teeth. Same thing with the jaw muscles and the bone joint. In my opinion, when people eat too much hard food, okay, their bodies condition themselves into doing things more and more, and they become more vulnerable, okay, more vulnerable for having problems there. You know, uh, Closing of the vertical dimension on page 124. Okay. Okay. So. I'm gonna just try to close up his conclusion, the last paragraph on the left-hand column on page 124. He says, closing the vertical dimension to an extreme degree could cause coronoid impingement against the zygoma, but it is highly unlikely that there would ever be a need for that much closure. Tenderness to palpation in the zygoma area would alert us to this. The only time that will really happen is, like I said, if somebody is wearing full denture and they take the denture out, okay, and somebody is over close. But here is the interesting thing, okay, that is, that is, again, he does not make the connection. When do we need to close the vertical dimension? Okay. He talks about, on the first paragraph, he says, unless it results in labially directed stress on the upper anterior teeth, there do not appear to be any problem associated with closing the vertical dimension on natural teeth. So he says there is not really a problem. It does not produce stress because a closed vertical dimension does not interfere with muscle length. Exactly. Exactly. So what I'm trying to say is, if you have enough space for the teeth restoration, somebody who has little too much space in phonetic testing, i.e., that you could actually open or close or whatever, okay? If there is no need for you to increase them, you can leave them alone at that vertical dimension, even if it appears to be slightly closed. That's not a problem. Okay. And if you're going to close somebody, but it's dictated by phonetic testing only. So if you do phonetic testing on somebody and they're just banging everywhere, that person's vertical dimension is too big. That's a clear indication that the muscles and the teeth are at war. Now, they can have phonetic interference in the anterior laterally, okay? And that's not necessarily a vertical issue, right? But if somebody has molar that is clearly in interference, okay? Oftentimes that needs to be that needs to be addressed by actually reducing. And you know what? Those are good examples of those cases. I don't remember finding any case here, but in the pictures here. But I'm sure you've seen some patients. Usually you'll see them younger still, on the younger side. Patients would have their first molars, 6-year molars, permanent teeth, number 3, 4, 3, 14, 19, 30, usually those, okay, where their their functional and balancing cusps wear away. There's no decay, they just wear away. And you keep putting composite on it, they keep wearing away. They keep wearing away. They pop off. If you actually put them through splint therapy, and if you do phonetic testing, for me, many patients in my practice, I've seen and determined that they have too much, their teeth are touching in phonetic testing in the posteriors. Their anteriors don't touch. You know why? Because the posteriors are touching. So in those cases, if I reduce the vertical dimension by making the overall teeth a little bit shorter in the back until there is no phonetic interference, and then do composite to fill in those holes, then those composites last a lot longer. Now, let's just say, so why would that be? Let's just say my number 3 and number 30 were supposed to be touching like this. And this person's vertical dimension muscle length relationship with the muscle length was just barely acceptable. But what if this person's maxilla did not expand large enough? So this person develops into a narrow jaw. So instead of being here like this, upper teeth are here. You notice how I had to move my teeth up in order to have them come in contact. What if they just go like this? Now they are in hyper contact. So they are forced to be opened up. So in phonetics, they keep bumping into each other. And it's not that much if you think about it. Okay. It could be just 1 or 2 millimeters. Okay. As they're growing up. But their body is trying to adapt to it. And it just perpetuates that bad relationship. What if they had that relationship on second molar as well? Well, now they become clincher grinders. Okay. So, so the value of at least putting it in your head, sometimes you may not be able to see it as clearly, as easily, but put it into your head the importance of uh, determining proper uh, uh, vertical dimension with phonetic testing. That is really the key to having stable full mouth rehab, or even for your family members, uh, preventing future breakdowns with their natural dentition. Okay, so keep that in mind. Okay, keep that in mind that that there is that interaction relationship between that keeps going on back and forth with the teeth position. A lot of times it's not so much that they are just tall, but it could have resulted just because they were slightly off by a millimeter or two laterally. Dr. Mylene, good morning.
Good morning. Hi. I have a question. So, with the phonetic testing, how can you see if the back teeth are touching?
Excellent question. Gosh, if I could just save $1 every time I got that question. So, so that is the challenge that we have, right? My I was a lucky guy because when I first tried the phonetic testing on one of my patients whom I suspected the posterior teeth interference, it was such an obvious case. And I was so lucky that the patient was one of my residents, and she immediately raised her hand and said, Dr. Lee, I never thought about it. Nobody asked me this question, but now that you're posing that question to me, are any of my teeth touching? My back teeth are touching. So if you're lucky and in a severe case, the patients will tell you if you tell them first what you're looking for. Have the patient become your assistant by telling them why you're doing phonetic testing. Okay, first. Okay. Now, a lot of times, unfortunately, they will not be able to help you, but sometimes you get lucky. Okay. Now, phonetic testing, um, when you are doing that, you need to, the here, I think he actually talks about um, the F sounds and the S sounds, right? Actually, the F sound he talks about it in a later chapter, I think. Okay. Now, let's just put it this way. Um, Usually, S sound and ch, ch sound is the one that gives it away. Now, the second thing is, you know how, like once you become really good at something, you just by glancing at it, you can tell certain things, right? I want you to practice phonetic testing so much that you're going to become like that. Because when you do, remember what I always tell you, that you're going to put your eyes on usually lower incisor. And you're going to notice whether they are class 1, 2, or 3, okay? And you're going to notice that the lower incisor is busy moving up and down, back and forth, sometimes even sideways, okay? When that when that lower incisor is moving, you're going to soon appreciate when the lower incisor moves, they move in a very, how should I put it, very fluid movement. Think of it as a very experienced um, ice skater. I think that's the best way. Women's ice skating, men's ice skating, because they are gliding on ice, you cannot really have too much of a jerky movement. When they jump up and down, they become a little jerky, but they are most of the times very fluid movement. Okay? When you notice, sometimes when you have them go to S sound, they will have a little jerky movement. Or when they go to the end of their envelope of movement, they come to a stop, even though they are making a couple of different sounds. So a good example is when I say Mississippi, okay, S. Every time I say S, okay, you should be able to see my jaw drop. S, S, S. But if you have them say Mississippi and you have them, you see the teeth come in contact, even if they say they're not contacting, they come up here and then they Mississippi. S, 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 S. The teeth are staying right there. That's an evidence that they are touching. They just don't know it. Okay? If they're touching in the back, they will also have, instead of having a elliptical motion, they'll have a jerky avoidance motion. The problem is, the challenge, not problem, the challenge is just like making a registration with CR is really, really hard because accurate CR is really, really hard because when the patients come in contact with initial contact, I'm sure you've been told, the jaw will deviate just ever so subtle. Okay? And that's why they say the most accurate bite registration is as close as you can have them contact, but not contacting. Okay? Same thing with the phonetic testing. When they touch, the brain picks it up subconsciously and they will try to avoid it. So if you keep doing phonetic testing for half an hour, everything gets muddled up. Phonetic testing is most accurate first couple of minutes. So what's the best way to do phonetic testing? Is actually when I'm interviewing them. A lot of times when I'm interviewing them, I look at their teeth. And I'm not looking at their teeth just for the shape of it and aesthetics of it. I'm actually looking at how they're talking. And then I get a pretty decent idea. And then I will do phonetic testing, emphasizing the S sounds, F sounds, and then the ch sound. And honestly, phonetic testing has to become part of your initial patient evaluation. When I'm doing initial evaluation, if I find anybody that I think has bite issue, okay, and if somebody has a bite issue, okay, I will, I will um, do phonetic testing. Okay, I'm not gonna say I do phonetic testing on 100% of times, So I end up doing phonetic testing maybe about 50, 60% of my patients. Even if there is no other symptoms. If somebody complains to me about TMJ, I do phonetic testing. And almost always they have lack of freedom. Okay. So, so, hopefully, you can practice this. It does take practicing. It really does take practicing. You know, they on page 126, he sort of goes through that, right? He goes through that, and he tells you to go ahead and do 60 through 66. Okay, that's fine. All the S's, 666. Okay. I find that besides San Francisco and Mississippi, I find Massachusetts also to be very helpful word. Okay. I think there is a later chapter he talks about the F sounds, right? The anterior teeth positioning. Okay. Okay. So you have to have all of them together. You cannot just do S sound. Okay. F gives you an idea about where the upper anterior teeth should be. S is where they interact with each other, primarily the front, but also the posterior, and then ch sound. Now, here's the interesting thing that I can tell you. Because I kind of eat and breathe this stuff, I can tell you about less than 5% of times, maybe less than that even, I do have posterior phonetic interference, but only occasionally. Okay. So I think it comes from the fact that I'm a class 3, so I have cuspal interferences sometimes. I can say that, probably I'm not really, my video is probably not too much. If anything, I can probably open my video a little bit if I wanted to, okay? And make me become a little bit more class 1 if I was to approach my dentition just restoratively and make it into class 1. I think there's room to do that, okay? But from my own experience, I can tell you there are days that phonetic testing is positive and there are days that it is negative. Okay. But almost always, I cannot think of one patient where I based their reconstruction or even to their TMJ or the orofacial pain treatments where I linked that to phonetic testing where I felt in hindsight that I was misled. I cannot remember any case that is the case. That they are invariably almost always tied to each other. That's why I rely on phonetic testing so much. And the good thing about phonetic testing is this. If somebody comes into your office and you want to do a big case, okay? The patient's interested in doing a big case, full mouth rehab or whatever, right? And invariably, oftentimes, especially if you have somebody like page 124, a lot of breakdown, you are asking yourself, can I open this patient? Because I need space to put teeth. Okay? If you are comfortable doing phonetic testing and figure out, okay, because phonetic testing can be used to determine vertical dimension, okay, I can immediately know if this case is something that I can do to meet the patient's expectation or not. So if somebody came in looking like page 124 and then told me that they want me to give them Hollywood smile, okay, without major surgery, that's not possible. Okay, not just because of the look this or that, but from my experience, if you do phonetic testing on patient on page 124, they're not gonna give me They're not going to give me 12 millimeters of space in the front where I need the room to give them good looking central incisor. Okay. So, so almost immediately I can rule that out. And if the patient is insisting that's how it has to look, then I can basically tell them, well, I'm not going to waste your time. Go find somebody else who can do that for you. I'm not even going to waste time using a splint to try to raise up their bite. No. Phonetic testing is really one of the most reliable method to determine VDO. Now, Dawson is quoting Silverman and Pound here, right? And those of you who had listened to my lectures, all of you know how many times that I recite Pound and give you the article that he wrote about this. Okay? And it's not just me. I am purely going by that. These are the people that I learned it from by reading their paper. And out of desperation, I started utilizing them in my practice, and bingo, I found the eureka. Okay. Now, um, he talks about using wax rim, because he's talking about denture case. Okay, and absolutely. So when you're using the wax rim for your denture case and things like that, okay, you look at those pictures in page 128. Okay, 128. Okay. So hey, figure 13-20 is he's giving you the example of F sound, V and F. Okay, upper incisors, wax rim needs to touch the lower lip, pretty much where he has it drawn. Wet dry juncture. It's an excellent picture to give you where ideally we want the F sound to be. Now, somebody may like how rabbits look. They want to have very strong, prominent incisor, and they want to make their teeth come out a little bit more forward. Fine. You can go ahead and do that. Okay. So from that wet dry juncture, you can have the upper incisor come slightly more forward. That's fine. Okay. Okay. Now, after that, you do 13-21. It kind of, um, when you say the like that, okay, like that, okay, he's telling you that there has to be the closest speaking space, that the sound has to be made comfortably, okay? And then I'm gonna say, ch sound as well, all right? And then, he's telling you you need to convert that to the denture teeth, okay? All right? You want your wax rim to be reasonably thin so that you can mimic denture teeth thickness. You cannot do wax trine with wax rim, okay? With wax rim that's just so thick that your tongue cannot move naturally. Okay, so the thickness of that, you really have to tell yourself that's ideally my wax rim. Okay, that's a little too thin to be honest, because it's not going to be stable. So I'll probably make it a little bit thicker than that, but certainly not as thick as what the labs will send you. So my recommendation is, I'm sure you read through the chapter. But at the end of the day, the only useful thing you need to remember that you need to practice is for vertical dimension is phonetic testing. Now, I'm in the process of, this coming week, I'm delivering a upper partial denture, lower partial denture, lower. This gentleman only has one tooth. Okay, number 31, and that's not much of a help. Um, Upper, he's got 5 teeth, number 9 through 13. Okay. And then he has his 104th birthday coming up this week. 104. Okay. And he wanted his teeth for his birthday present. So I'm doing everything I can to give it to him. Okay. And, he doesn't have good muscle coordination, to be honest. Right. And all that. So, so when I tried in the wax try-in first, and when I did my teeth try-in, even though I did do phonetic testing as well, guess what? I went ahead and frankly gave him the vertical dimension at his CR, okay, with a closing that is slightly allowing this angle of the mandible, I mean, not angle, the mouth, the corner of the mouth to be slightly closed. 104, right? I don't want his lips to be so taut that there is no fold here. We want to give him a little bit more fold or whatnot. There is some truth to what looks normal to be in the ballpark, right? So there is nothing wrong with using all of those common sense to help you get close to vertical dimension. You know, and with 104, I am not going to spend half an hour doing phonetic testing, right? But here's the thing. Remember what I said a little bit earlier? It's okay to be slightly overclosed. What you don't want, especially denture patients, you don't want to be open too much. Because if you're open too much, the dentures clank onto each other. Patients don't know. Guess what? Your denture is always falling out. Okay? So knowing that from the beginning, I want him to look decent. And if I'm going to error on it, I'm going to close it a little bit more. And then I'm going to do phonetic testing. Make sure there is no gross violation. Okay? So if you sort of follow through that, then vertical dimension is not a magical concept. It's a range, just like CR. It's just a range where my hands, my arm is comfortable here or about here. It's a range. What I don't want is I don't want to be out here, and I don't want to be out here. Okay, so so hopefully this was a nice practical discussion about the vertical dimension. Okay. When in doubt, all of you have access to that article that I gave you the link to, um, Earl Pound. Okay. In the phonetics, the S sound, the pilot to vertical dimension, or something like that. Okay. You can Google it. I always tell everybody that's probably the biggest contribution Glidewell Lab made for dentistry by having a PDF file of that on their website. So if you Google Earl Pound, let S be your guide, vertical dimension, you're going to get that article. Okay? And print it out, read it several times so you can get understanding of that. Okay. Okay, let's get into neutral zone. Neutral zone and envelope of function is going to be somewhat similar idea. So it's 10:30 right now. I need to have a little potty break. Why don't we take a 15-minute potty break here? Okay. Why don't we regroup at 10:45? Okay, so that's 12 minutes. 10:45. Okay, everybody? Thank you. So I saw the little question that Mari had sent me uh, when I took the break, when we took the break, that that what you might call it. So he was asking, So if you determine that somebody, through phonetic testing, that somebody has interference, and you decided that you need to do some occlusal equilibration adjustment to improve that, how do you mark it? How do you do it? Well, as you know, we can't have them give us phonetic testing with tapes in their mouth. So that is the frustrating thing about phonetic testing, and how to translate that into what we do. So I thought about that many times. There is really no good way of doing that other than you identify where the likely interference is, and then you check your CR contacts, occlusal contacts, and then you go through excursive movement contacts, and then you will start to see where you have the interference likely to occurring um, through the excursive context and CR context. So you have to sort of kind of add it together. Patient, it appears like the patient has a molar interference. If I'm looking at the molar interference in CR and then in excursive, if there is a definite excursive interference, I get rid of that first, assuming that the CR is even equal contact. But let's say in CR there is not equal contact. That means I need to do occlusal equilibration, so there is more even contact in CR first. And then after that, if you still think there is occlusal equilibration, phonetic interference, then I go through excursive contacts, and I'll go ahead and start adjusting those at that at that CR once I am happy with the CR. I hope that makes sense to you, Mari. Okay. I know that adjustment requires a little bit more patience, and you have to, again, there is no digital way of doing this. You have to do this analog. You're the one who has to make it happen. But when you start doing that, when you start to see clear cause and effect benefits to your patients, you become it's very satisfying, very gratifying to see how that works. And I can assure you, it really does help with that. So you're always checking the CR first. Make sure your CR contact is nice and even, or even enough before you go through excursives. Make sure there is no interference in excursives. Once you're reasonably happy with excursives, those patients who are going to tell you, oh, I have many different bites, I need to check my bite while I'm sitting up. After you're done with the CR and excursive in supine position, then you can have them sit up and then go through the checking again. Okay? But I do not check their bite only in their sitting position, nor do I even start at that position, because what they are telling me is they have a CO that's significantly different from CR. But CR is really the home position. That's the anatomically centric position that, unbeknownst to the patient needs to be able to become free of interference in CR. Okay, so feel free to pose any follow-up questions to that if you'd like. Let's talk about neutral zone. Neutral zone is actually really not that difficult of a concept, but many times we don't actually think about this. I actually recently had a case where one of my colleagues was trying to restore with implants lower anterior. And patient had sort of flared out teeth, worn down, again, elderly patient. So they went ahead and put nicely positioned implants. And then they went ahead and made a fabricated bridge, but the patient kept saying, "I'm not comfortable. I am not happy. I can't chew." Da 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 da. And when I finally had the chance to see the patient, okay, even phonetically, she didn't really have a lot of interference or anything like that. But what I could see was that her tongue space was constricted. So you know that in some cases, let's see, we don't have any pictures of the, yeah, there you go. So picture page 134, figure 14-8. So if you look at that, imagine imagine the patient lost all the incisors and the canines on that drawing. Okay? And when the lab made the final restoration, they made the canine to canine front teeth instead of an arc, they made a straight line, right? Patient's gonna lose good 2 millimeters at least of that tongue space. Okay. So what I had to do to prove this was I made it into a new temporary, and I made the lower front teeth bulge out to the front. Okay. But in order for me to do that, what did I have to do? I had to lower the incisal edge, right? Because when you're further back, you can make the front teeth taller and they don't interfere as much, right? But if the teeth are more forward, right, they're more likely to bump into the upper teeth, right? Same height. Well, how do you minimize that? You need to reduce the overbite. Okay, so that's what I ended up doing. I carved out the tongue space. I added to the buccal dimension, and then I lowered the incisal edge so that they are not bumping into the upper teeth too much. And I had to do that a couple of times, but on the first visit that I did that, patient goes, "Oh wow, this feels so much better." And when the patient came back, I had to do a little bit more, okay, to carve out the tongue space. And finally, after about a month in the temporary, patient goes, "Yeah, Dr. Lee, if you can give me the new teeth with this dimension, I think I'm gonna be okay." Okay. So those are the type of situations where if you're gonna do a lot of implants, okay, you don't have the root prep, the teeth preparations to guide you where the teeth ought to be. And then when the bone, alveolar bone resorbs, you lose track of where the bone and the dental arch, dental arch used to be, right? So you need to follow through with the idea of neutral zone. Now, let's go back to the neutral zone idea on page 132. Let's read what he says here. It says on the left-hand column, he says, teeth are the most movable part of the mascatory system. I know what he means. We all know what he means. But guess what? No, he's wrong on that. No, the most movable part of the mascatory system is muscle. Muscle, 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 muscle. Okay? Teeth are not moving. It's the jaw that's moving. Right? Yeah. But it's this kind of oversimplified statements that throws people off, the dentist off, when they're trying to study. When you're chewing, the teeth are not moving. It's the bone that's moving. It's the muscle that's making the bone that move. Of course, the teeth are moving in three-dimensional space, yes. And we do control the shape of the teeth, yes. But 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 I'm not trying to like nitpick on the word choice. I'm just trying to emphasize to all of us, it's the muscle, it's the muscle, it's the muscle. Okay? And then he says, if outward horizontal forces from the tongue are greater than inward forces exerted by the buccinated muscle bands and the lips. The teeth will not horizontal teeth will move horizontally until the opposing forces are equal. This is neutral zone. Okay, fair enough. But here is the thing. I think it's unfair to say that our buccinator, our orbicularis oris, all those muscles are as influential as our tongue. Those of you who may not have the Christian background, I joke around just because I'm more familiar with the Bible. I say I say to everybody, jokingly, I say to everybody, in dentistry, tongue is the source of all the evils. And the book of James in New Testament, I believe it's James, where he says that exact phrase. Tongue is the source of all the evils. He's not talking about dentistry. He's talking about the words that we say, right, in this world. Okay, I'm being facetious here, but tongue is what controls. Tongue is what controls. Okay, so much about our teeth. Okay, when 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 somebody's arch is too narrow, maxillary arch, like 136A, page 136A. Okay. Um, and we want to make it into looking like 136B. I'm sorry, 14-11B. Okay. Okay. Oftentimes, it's not necessarily because the tongue was thrusting, like he's saying, and tongue became narrower. Actually, no. What really happens is the tongue did not want to go up there. So we all learn, I hope you did, that the way that babies' arches develop, the best observation that we can make is when the babies are suckling milk from mom, okay, the tongue pushes up against the upper jaw, edentulous jaw, and it does this, okay, and the tongue forms the width and the shape of the upper arch, okay, and the mandible follows that, okay. But if the tongue has too much of lingual frenum attachment, strong lingual frenum attachment, so the baby cannot really be comfortable to leave the tongue up on the roof of the mouth. Except for when they're suckling, the tongue stays down here. Tongue stays down here all the time. Well, then what ends up happening is tongue is forming the mandibular shape, not maxillary shape. Okay? And if you look at maxilla versus mandible, if you kind of look at that arch together, at least in class 1, mandible has to fit within the maxilla. But if the tongue that should be forming maxilla is actually on the mandible, think about it, by default, mandible becomes a little bit larger. There goes our class 1 becoming class 3. Or if it's not the lingual frenum that's doing that, kids can have a cold, a very bad cold. Their nose gets stuffed up. Okay? They can't breathe through their nose for half the year, or they have an allergy. They can't breathe through their nose. So what do people do if they can't breathe through their nose? They have to breathe through their mouth. If they are breathing through their mouth, what ends up happening? Can you truly do a lot of breathing through your mouth with your tongue to the roof of your mouth? You can, but that's not really a natural thing to do. what ends up happening when people are breathing through their mouth, especially when they're asleep, is the tongue and the jaw drop down, tongue and the jaw come forward a little bit. Okay? So maxilla doesn't get the stimulation to grow. So maxilla is underdeveloped. Mandible keeps getting the stimulation to grow. Mandible overdevelops. Okay? And that is how a lot of our modern day malocclusion starts. Okay? Now, a lot of people blamed it on lingual frenum. Okay? And I think there's some truth to that. Okay? Okay? But it's not just lingual frenum. It's not just lingual frenum. Okay? I think when the kids have allergies and kids have certain cold and they become, mouth breathers, that sets it up. Okay. So if the tongue becomes comfortable being down and forward all the time, well, then I think it's not unreasonable to think they look as if they're becoming tongue thrusters. In my humble opinion, yes, there are truly certain patients who are tongue thrusters, but I think a lot of them are not true tongue thrusters. It's more of an adaptation. More of an adaptation. Okay. And so it is important that we need to have shape, okay, to accommodate the arch shape. That's what I meant to say. Arch shape to accommodate the shape of the tongue. Okay. I'm sure you notice some people that you look at their tongue and they have all these ridges at the edge, right? Because they've been clenching. But it's also because, just like I said earlier about what? I said earlier, I said, the good Lord, God, the creator, sometimes makes gets things mixed up. Small jaw, big teeth. Well, there's certainly room for another error, that is small jaw, big tongue. Okay? Yeah. If all of us look different, if all of us have different height, different width, different forward back, all kinds of different appearance, right? Why do we assume everybody's tongue size is going to be the same? No. So, so it's an important concept, but I personally feel that the lip and the thing is secondary. I'm not saying they don't have anything to do with it, but it's really secondary. It is the tongue. Tongue is the one of the most critical aspect of the dental arch development. And if the arch is not properly developed, then we have problem with uh, with um, with um, the relationship between the upper and lower, and the relationship between all the different muscles there. And then add to that, I would say there are some people that, I have some patients in my office. I frankly am amazed at how narrow their arch is. Some of them, okay, and uh, you know, I don't know if that is hereditary. I would imagine in a certain genetic predisposition to a certain shape has some effect on it. I do know, for example, at least from an orthodontic perspective, in my class 3 can be explained by maybe a slight overdevelopment of my mandible and slight underdevelopment of my maxilla. Was it because I did not raise my tongue to the roof of the mouth? And I think I probably fit into that category because until I became aware of it, once I became aware of this relationship long time ago, and then I started observing myself, and I realized, you know what? On, I noticed my tongue is parked at behind my lower front teeth more than parked behind the upper front teeth more. And I try to tell myself, remind myself to do that all the time. Okay. But it is that. So there is probably a certain hereditary component. And if that led to my midfacial growth deficiency, that's what orthodontists will say. Okay. And that's why my chin and so forth should have been, could have been slightly more developed and I did not. Okay. But the important thing is, especially as we're doing implant restorations, okay, this is a critical thing. And those of you who might later on do all on four, all on six type of implant restorations, you have to be careful about this. And that is this, that, that if you look at, take a look at the picture on page 133, figure 14-4, just because I think that's the best example I can take picture right now. Imagine that picture with the teeth and everything. Teeth are gone, okay? Or they're severely compromised, and you're running your office and you propose to the patient and the patient agrees to doing all on four, all on six, all on X. We're just going to talk about the maxilla, okay? So the oral surgeon, what they're going to do is, because some of the mouth, some of the alveolar housing on the maxilla would be still more protected, like the bone's still there, some areas they've been resorbed, but they want to have an even bone height. That makes it easier, right? So what do? They will do ostectomy. They will grind the bone down to get to the even height. So if you take an arch like this, you take a look at where the alveolar bone is, the basal bone is, and the teeth are. And if you grind down the bone to get even bone height, your arch becomes narrower. Because if you look at maxilla from the palate to the alveolar bone, to the front and to the side, the maxilla spreads out like this. You trim it down so that you have bone that's going to be more even. They are going to be, your arch becomes narrower. That's what I'm trying to say. And I've seen this happen many times where the patients had all on X procedure done somewhere else, and they come to me because they are having problems. And almost every case, right now I can't think of any non-case, every case, their tongue runs out of space. Because the all on X prosthesis is narrower. Now they try to bring the teeth out to compensate for it because they want people to have class 1 occlusion, okay? But the implants are getting in the way of the tongue. And that's exactly what the example that I gave you about this patient in the lower front too, because implants in the bone. Okay. So this idea about protecting tongue space in restorative dentistry is critical, absolutely critical. And some of you, I sometimes will tell you, when you are doing implant crowns on number, I just had recently done this, number 19, number 20, I'm sorry, 18, 19, 20, something like that, I think. Or was it 18, 19 only? Anyway, um, my lab is fabricating crowns for implants, and I had to go back and tell them, get rid of the lingual half of number 18. Why is that? Because when the bone resorbed, they resorb from buccal to lingual, towards lingual. So implants going on the lingual. And then when you make an implant crown on that and you give a lingual cusp, you are impinging onto the tongue space from the side. Especially when the patient may have been used to not having any teeth for a long time and the tongue was occupying all that space. If it gets to be really extreme, patient will come in complain to you about their tongue biting. But usually it doesn't get that bad. The tongue knows how to avoid it. But it is uncomfortable. And it creates a lot of undercut area to the tissue and cleansing a challenge. Okay. So what I tell the lab to do is no patient's gonna complain to me about how their second molar looks if they're comfortable. So I basically told them from the central fossa to the whole lingual wall, get rid of that. Okay. Now, the second molar implant crown oftentimes will look even smaller than bicuspid. I tell you to always try to make molar implant crowns look like a bicuspid. Sometimes second molar, because of that funny relationship, sometimes they end up becoming even smaller than bicuspid. Okay, because that's where the tongue and the lower arch come into some of the biggest conflicts with the space issue. Okay, so always be on the lookout for tongue as well. Very few people do that, right? The lab's never going to think of it for you. But you have to catch that before you commit your time and resource to violate that tongue space, and you struggle for 6 months, and then the patient's never happy. Okay? That's why this concept of neutral zone is important for you to keep in mind. It doesn't play obvious role every day, but when it does play, it's a critical role. Okay? The and the example of the patient about the lower front where the arch was just too flat and that's why the tongue patient didn't have any problem. I mean, patient didn't have any comfort. Patient didn't like it, and patient kept saying, "I don't like it. I don't like it." She doesn't know how to describe it, and the restorative dentist didn't know what the hell was going on. And I'm not saying I'm so good. No, another prosthodontist was consulted. And you know what the prosthodontist conclusion was? Patient's just a difficult patient. Yeah. And guess what oftentimes ends up happening with patients like that between that prosthodontist and that restorative dentist and that periodontist? They start saying patient's difficult. Oh, it's psychosomatic. And patient starts to go crazy. Not because the patient was crazy. All these doctors are making the patient crazy. You know? Honestly, the prosthodontist official opinion was patient's difficult patient. This is all we can do. Okay? And I spent an hour and patients like saying, no, now I'm happy. Okay? So, important. Okay? Whether it's tongue, whether it's the lip, okay? Whether it's the jaw movement or whatever it is. Remember, respect the muscle. All of them are muscles. Okay, that's ultimately the message from this chapter. Okay, now because of this, I happen to think a GP who understands occlusion like we are talking about, if you should decide to become, if you should decide to do some orthodontic work, and I've seen some of the best orthodontic work being done by GPs. Because I have never heard of an orthodontist talking about tongue space. Now they talk about it in the context of arch development, yes, But they talk about it as an arch development. They don't talk about it as making space for the tongue. That's what I'm trying to say. Okay? I mean, it sort of goes hand in hand, but what I'm just trying to emphasize to you, think of tongue as a separate entity that needs to be satisfied. Needs to be satisfied. Okay? So keep that in mind. I hope you will remember what I said about the example of the lower front patient. Okay? How there was not enough space. Doesn't matter if even if you satisfy all the other Tomley requirement. It doesn't touch eccentric. It only touches in excursives and all that. Doesn't matter if there's not enough tongue space. And in the maxilla, if those people had gone to an oral surgeon, they chopped down the alveolar process and put the implants in, and now we're stuck in that palatal lack of space. It's just such an uphill battle, such an uphill battle. And the interesting thing is this. So, you know where I started thinking about that. Initially, I wasn't actually thinking about it for a long time, and then one time, one of my oral surgeon friend goes, Tom, when I do this all on four, all on six cases, I always end up with deep pockets. He goes, he goes, I don't like it. I go, yeah, I don't like it either. He goes, what do you think is the problem? And I couldn't, he's pretty experienced oral surgeon about my age. So I was actually surprised that he was asking that question, not because I'm saying I know so much better, but because he's the one who created that deep pocket. Why? Because when they do alveolectomy to make it even, okay? So let's say I reduce my alveolar bone by 3 millimeters to make it even. Do they trim away mucosal tissues by 3 millimeters? No, they should, but they don't. Because you know why? Because that takes actually more time and so less satisfying. Because when you trim away 3 millimeters, truly, you're going to end up with what? Basically just mucosal tissue, non-keratinized tissue. So there's part of them, the surgeon, that says, I want to preserve my keratinized tissue. I don't want to touch my soft tissue. Yes, but you took away the bone. So when the tissues heal, now you have 3 millimeters of extra bone, of extra soft tissue. That's on top of the bone. Does that make sense, right? Yeah. So so now so why do they do the bone flattening? For their convenience. It's really more for convenience rather than to work with the patient's bone physiology. Allow them time to heal, maybe graft some bone, you know. It's because they want to do it on the same one visit. And these poor patients end up suffering. Okay. So let's just keep in mind importance of respecting soft tissue, the muscles, the tongue. Neutral zone is all about the tongue, the balance between tongue and the lip. But the lip is not as critical. Lip, to me, is more of a passive participant. Tongue is an active participant. Okay? Sounds good? Okay. Now, let's go to I think you have, I talked about pretty much all the things that we need to talk about. Okay. One thing that's interesting is I couldn't kind of let it go. Is it's kind of a preview about occlusion. Is page 139. Take a look at that the B, okay, the denture drawing of the lower, okay. That is something that I wanted to just remind all of you. Okay, number one, the denture surface, the flange, denture flange that is against the tongue should be concave, just like that drawing. So it is the tongue shape that should help stabilize your denture. Instead of that concavity against the tongue in the denture flange area, if it became convex, as in it sticks out, which almost all the denture that the lab sends you, then the tongue will keep on rubbing against it and most likely lift it up, lift it up. Okay, so you could have gotten perfect border molding, but because the lab gave you wrong shape of the flange, your denture is not stable. So neutral zone is a critical concept in denture, obviously. So I wanted you to keep in mind how that picture looks like. Okay, page 139. Okay, figure 11-14, B. Okay, where the denture comes up against the tongue, it needs to be overall concave. Allow the natural shape of the tongue muscle to help you retain the denture. The same manner, the same manner, the buccinator muscle, okay, on the cheek side, it tells you the same thing. You want the flange to be slightly concave. That's how you stabilize the denture. Okay? Thank you. Thank you. Okay? All right? So it is absolutely important, okay? That when you are, because you're going to be making a lot of flippers, a lot of treatment partials, and things like that, okay? And you take a look at it. Almost always, the labs will give you bulbous flange. Now, it's difficult because when you start carving out, sometimes they get too thin. You're exactly right. So you have to think about, do I make it a little bit thicker first so that I can carve out? Sometimes that's what I do. I have to add to the flange end to make it a little bit thicker rather than just carving. But when you are instructing the lab, when you are having the lab do the work, it pays to talk to the lab. It pays to write a little bit more description. Now, I had a case, actually, it's that lower anterior case recently. So in order to communicate with the lab about the angulation, because I made a temporary impression sent to the lab, I didn't trust the lab would follow through. So it was a new lab I was working with because I was working with the same lab that the restorative dentist had worked with. So I told the lab, hey guys, I want to see you in person because this is a zirconia bridge that they're making. So everything's going to be done digitally. I want to see you in person so I can go over exactly the details of it. So I went and visited them. I sat next to the designer, every aspect of it. I have them control it. I have them control the embrasure space, emergence profile of each abutment, and all of that. Okay. If I do that, if I'm willing to I spend 2 hours driving that stupid lab each way. Okay. Patient has no idea what goes in, but guess what? That is the only way I can make sure that everybody's going to be happy, or I have a chance to make everybody happy. Because for the patient, it's the third prosthesis. I think the patient deserves that little extra help, right? So, so I want all of you to to um, to have that commitment to make it right and do it first proactively with the lab. Instead of just complaining the lab's not doing a good job, we have to guide the lab. With all due respect to the lab, most of them don't even have associate's degree in dental technology. You know, America, supposedly the world's most developed country in the world, I think I told you this many times before, is one of the few developed countries in the world where there is zero legal requirement for somebody to call themselves dental laboratory technician. You know, there is no governmental effort or ADA effort to try to put in some minimal standard into our profession. Okay. So you have to take the lead on that. And so I wanted to emphasize that from that drawing. Okay. I thought that was actually nice drawing for that purpose. Okay. And then I also wanted to say that take a look at the occlusion. That is indeed primarily the occlusal relationship in the posterior that I want to establish. Cuspal tips contacting opposing fossa or marginal ridge. Opposing fossa, marginal ridge is not a deep valley, but more of a broad U-shaped receptacle. Your cusps are more like a V going into a U-shaped receptacle. Okay? But they are not touching on the side. They are not touching on the side. Burnish that picture into your head. When you are doing occlusal adjustment, that's what you're trying to create. Okay? I hope that was helpful. Okay? Now, another reiteration I can give you on the opposite side, the black and white picture of the mounted cast. You see how the lower anterior segment is over erupted, like we were saying earlier. Okay? I mean, it's this poor patient. It's clearly an indication either the anterior teeth are in interference or the posterior teeth are under erupted and it's lack of posterior support. It's not even a vertical dimension issue. You know, it's either one is in interference or one didn't erupt enough. You know, so so I think it's really, when you start to look at things slightly differently than how the book is presenting to us, then you start to see the commonalities of the problems, and it becomes easier and easier. Okay, so so I will interesting here, page 140. I kind of chuckled at the end. Um, on the left-hand column, 140, determining the neutral zone for anterior teeth. Okay. Second paragraph in that section. Phonetic methods can be used with a high degree of accuracy because the shaping of sounds results from precise approximation of upper and lower teeth with each other, with the lip and with the tongue. Yeah, exactly. Exactly. That's why I keep emphasizing phonetic testing. Okay? Now, he talks about methods of altering the neutral zone. Orthodontics, yes. Uh, get rid of habits, noxious habits. Those of you who are not familiar with myofunctional therapy, basically you can think of it as a therapy where they learn to put their tongue in a certain position, learn to speak in a certain way, enunciate, so that they're controlling their lip better. Okay. Unfortunately, it's a dying art, meaning like I think in the entire LA County area, there's only one or two people who are doing that. No dentist certainly is doing that. Okay. And I'm not even sure if there is any official certifying body for that. Okay. So I think it's that's kind of sad. But I will say that I've seen some mixed results from the patients who have been through that. I do think it's helpful for them to become aware of things. And my take, and I met actually one of those therapists so that I can get to know what they were doing. And essentially, it's self-awareness, learning to position the tongue in the upper front area. So essentially, your tongue tip of your tongue should be at the nasopalatine papilla. That's where they need to rest throughout the day. More they rest there, better it is. And if you have lingual frenum, that makes it challenging. The myofunctional therapist will say, cut that. And they sometimes will put little acrylic there with a retainer, so that they have something that constantly reminds them to put their tongue there and things like that. Okay, but that's the basic. I mean, I know that that's a grossly understatement of what they're doing, but they teach them how to do jaw exercises. And one more thing, since I'm at the topic of a jaw exercise, I'm sure we'll eventually talk about this again when we talk about the TMJs. But the best way for the patients to do jaw exercise, especially if they have muscle pain and the joint pain, those of you who are not familiar with it, is you have them open and close, but when they are opening, they need to consciously slide the jaw down as they're opening. They don't just open and close. When they're opening, slide your jaw down forward. So you are doing translating and rotating at the same time. And what that allows you to do is your disc does not unnecessarily get dislocated. When your jaw is coming forward like that, it comes down with the glides down with the disc as much as it can. Okay? So if the patients do that, at least those people who are getting mild dislocation of the disc, internal derangement, they will start to feel better. Okay. Reduction of tongue size, we talked about it. In my career, I've only seen one patient who had tongue reduction surgery, and patient didn't really want to talk about it. Patient said that was not fun. So I'm not about to recommend that to anybody. I honestly can't imagine, you know, um, how that it will even work out afterwards. Okay. But theoretically, that is something that can be done, and occasionally, very occasionally, they can be done. Surgical lengthening of the buccinator muscle band. Eh, again, same idea. I'm not really sure if that's what it is. Um, in my opinion, I think it's the tongue size and the muscles length is something that I think we can work around it almost all the time, unless they have certain injury or hereditary condition that really makes it, a rare situation. Vestibuloplasty is a something that we talk about with dentures and implants. Okay, um, that I think that's kind of a stretch for most of the times. Okay, um, but what I wanted to say was that those of you who might be familiar, you may have heard other older dentists talk. that when people go through orthognathic surgery, the last one, orthognathic surgery, that there's a lot of relapse. And my personal opinion is that it's because they only move the bone and they shape the teeth, but they have no consideration for the muscles, either the tongue or the buccinator masseter muscles. And that's why they do have the relapse. And if you think about it, same reason for orthodontic treatment. A lot of times orthodontic treatments have relapses because we have not addressed the tongue issue most of the times. So please be aware of the tongue issue as we are always thinking about these neutral zone occlusion ideas. Okay. So now let's get to the envelope of function. Okay, and envelope of function, there's a lot of different concepts here that we need to talk about. But um, so so let me take a deep breath here because this I have just about entire page highlighted for me. So I need to it's a short chapter, but I basically um, um, so let's go to page 142. So the very first sentence, function. The functional movement of the mandible constitute the most fundamental basis for ideal occlusal design. Okay? And then the second paragraph, first sentence, the starting point for understanding the envelope of function is to first understand the envelope of motion. You can say envelope of function and envelope of motion is same, slightly different, but basically almost the same. Okay? So envelope of motion means the maximum range that the mandible can move. Envelope of function is going to be a little bit less than that because in our normal function, we don't go to the as extreme edge of that limit. Okay? To me, envelope of function is really now getting closer to envelope of phonetic movement. Okay? Now, envelope of motion, you mean the maximum they can move around. Recording of pantographic tracing or stereographic tracing, the old-fashioned ethologic method, was to understand the envelope of motion. And if you can understand, or if you can have a concept of envelope of motion, how much the jaw is able to move, and if you accommodate that, then envelope of function is naturally accommodated because envelope of function is going to be smaller. Okay? The reality is this. Envelope of function is dictated mostly by muscle. Envelope of function, I want to make sure, envelope of function is determined by muscle. Envelope of motion, which is the maximum, that's determined by the ligaments and the joints and the bone. Okay? Now, the critical thing about all this is that your envelope of function, okay, needs to be in harmony with your anterior guidance or group function or make sure there is no interference and things like that. But occasionally, if the patient is, let's say, asleep and they have parafunctional habits of grinding, clenching, and this and that, that movement can exceed envelope of function. And that is why only thinking about envelope of function may not be adequate. that envelope of motion, that the maximum range that the jaw can move about is something that we need to satisfy. Now, it is extremely difficult to prepare your teeth to that, okay? Because most of the times patients don't move that much, no matter how much we try to induce them to do that. And in my opinion, that's where a somebody who has a high risk factor, that's where a night guard can be very helpful. When you fabricate a flat plane night guard, if the patient goes through extreme excursive, extreme grinding to the point where they exceed envelope of function, at least you're minimizing the potential teeth to teeth damage, okay, by putting in an acrylic that allows the jaw to move about sideways easy. Okay. Now he talks about um, let's talk about just so that I can give you some background on this here. Uh, I think I summarized it okay, but just to kind of confirm with you that you know where to find what I just said. Page 142, under envelope of motion on the left-hand column, okay? First sentence, every tooth in the mandible, the only moving jaw, has an envelope of motion that outlines the outer limits of which each lower teeth can be moved, okay? These limits of movement are imposed on the mandible to a large degree. The limits of mandibular movements are directly related to limits imposed by ligaments, bone, and muscle on the temporomandibular joint. Okay? So you understand, envelope of motion is dictated by bone, ligaments, and the joints, and the muscle, yes, okay? But that is what that is. Okay? Now, envelope of uh, where am I? Envelope of function now. Excuse me. Okay. The first thing on the right-hand column of page 142, the first thing to understand about the envelope of function is that the functional movements of the mandible occur within the envelope of motion and cannot be determined by recording the border movements of the condyles. Recording of the border movements of the condyles is what Dawson said on the prior paragraph. He talks about how uh, some early pioneers in occlusion and restorative dentistry surmised that if the border movements of the condyles controlled the envelope of motion of the mandible, recording the condylar path and copying it on a fully adjustable articulator would provide a precise method for occlusal analysis and treatment. Out of this concept, nethology was born. The development of pantographic tracing devices was perfected, and the recording of condylar pathways became the standard for quality occlusal treatment by a fast-growing cadre of nethologists. And he goes on to say, I must admit that for some time I was a proponent of nethologic concepts. Nethologic concepts are very, very helpful. And certainly, I think I consider myself a trained nethologist because I learned to do that. Okay? It is definitely helpful. But what Dawson is saying that on the part about envelope of function, meaning that, but rarely do we go to that extreme. That is also true, and that is why most of the times, in fact, I haven't used my articulator and I haven't done pantographic tracing since I left my PROS program. I haven't done it, period. Now, instead of that, I've done stereographic tracing, which is a little bit easier to do. Same concept. Even that, I haven't done that for 10, 15 years. Okay. by recognizing envelope of function is really all I need to really accommodate. And occasionally, there will be people who will challenge that by bringing their jaw movements beyond envelope of function. And that's why sometimes just doing occlusal adjustment is not enough. And that's where I frankly feel like, you know what? Maybe night guard will be helpful. Now, if I wanted to go back and in retro and do full pantographic tracing of stereographic tracing, I'm sure I can uncover some problems with those patients. The problem is, to be honest, uh, they are too complicated, takes very time consuming. It is extremely difficult to justify doing that preemptively on patients. Okay. So that's my excuse for not doing that anymore. Okay. And I frankly don't know. I was always stumped, like, in a teaching environment, teaching school environment, you know, you do it regardless of the cost anyway, but in private practice, let's say if I wanted to gather all the armamentarium I need for pantographic tracing, and if I think about all the things that I need to do for preparation and actually doing it, it would be at least half a day. How much do I want to charge for my patient for half a day? 4 hours. I'm going to say minimum $2,000. How many patients are going to pay for that? Okay. So that's where I'm gonna have a little bit of a reservation about doing that all the time, and that's where I contracted, reduced my uh, number of patients that I was doing that with. Okay. So here's an interesting concept here, interesting statement. Page 143. Okay, under the section of influence of teeth. Okay. So now let's just read this part here because now we're talking about teeth. Okay. Let's look at it at the determinants of occlusion. You will see that the condylar path dictates how the back end of the mandible moves. So imagine, okay, condylar path, okay, determine the back end of the mandibular movements, okay? That is the first determinant of occlusion. The second determinant is controlled by teeth. Ideally, that is the anterior guidance, which determines how the front end of the mandible moves. In a perfect occlusion, the combination of the condylar guidance and uh, uh, anterior guidance determines the path that the mandible follows in function. What he's saying is, in a perfect occlusion, the the condylar guidance and anterior guidance, okay, they have to sort of work together. Okay, so I want you to know, I want you to know that this is, in an ideal world, how it should be. But guess what? If anterior guidance is there only because of teeth, but condylar guidance is there regardless of the teeth, shouldn't it be that the anterior guidance really follow the condylar guidance anyway? Yeah. But people don't want to say that because then that kind of diminishes anterior guidance. And that's where we have the dilemma. Another argument that I want to tell you, anterior guidance is overrated. Anterior guidance only works if it's in harmony with condylar guidance and the muscle. Anterior guidance cannot win over the others. And the others couldn't care less if anterior guidance is not there. This goes almost directly against what a lot of lectures that you're going to hear about occlusion. So you're gonna have dilemma about this. I understand. I don't have anything against anterior guidance. I just want anterior guidance to know what its limitations are. Okay? The limitation of anterior guidance, okay, is is that it cannot override the others. When it overrides the others, eventually they break down. Okay? Okay. Now, here's the interesting thing. The concept of harmony on the right side. Okay? Okay, anyway, before that, it just jumped out at me because I basically have the entire page highlighted. I want to read the on the right hand column, the first paragraph, because every time he talks about the nathologist, I'm kind of interested because I kind of see myself as an evolved from a nathology that I learned. The early nathologists did not understand that the anterior guidance is not determined by the envelope of motion. I think that's a misstatement. Nobody ever said that 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 anterior guidance is determined by envelope of motion. No. Rather, the anterior guidance is determined by the envelope of function. Okay, okay. But even that is not determined by that. Actually, anterior guidance helps to determine, in many cases, the envelope of function. If your guidance is truly working, that's telling you how far your jaw can go. Isn't that controlling the envelope of function? Okay. And it varies from patient to patient regardless of the condylar path or the envelope of motion. There is no need or advantage of this any kind for the anterior guidance to be the same as condylar guidance. So if the anterior guidance is not there, then what you have is just condylar guidance. If your anterior guidance limits your condylar guidance's movement, then that would be considered envelope of function plus anterior guidance, I guess. Your anterior guidance can restrict your jaw movement, yet it cannot it cannot overrule your your functional movement, at least not for long. I know I'm repeating that. I just want you to keep in mind the way that we were taught was if I were to use pantographic and fully articulated, full articulator, fully adjustable articulator, okay? The way that we were taught is make your posterior anatomy and the aesthetics fit to the condylar guidance, and then you just give your anterior guidance just a little bit, about half a millimeter of less movement. That's where we started. That's how we did the wax up. That's how we made the initial provisionals. And then from there, we accommodate patients' need for more movement or not, whatever. And then that's how the final restoration came about. Okay. So anterior guidance, if that is totally disrespectful of condyle, will fail. If you want to use anterior guidance as a adjunctive to condylar understanding of your condyle, then I think you have a very good chance that will work. Okay. Okay. So let's read this concept of harmony because, yes, occlusion needs to be in harmony. Okay. When restoring upper anterior teeth, the lingual contour should be in harmony with the envelope of function from the centric relation contact to incisal edge positions. It is not enough to be in non-interference to the envelope of function. If best appearance, best function, best phonetics, and best long-term stability are to be achieved, the upper incisal edge must be in harmony with the envelope of function. What does he mean by harmony? Let's keep on reading. Of all mistakes that can be made in restorative or orthodontic treatment, restriction of the envelope of function is one of the most problematic. Putting anterior teeth into relationships that restricts a more horizontal envelope of function is an almost certain cause of excessive wear, mobility, or forced movement of the anterior teeth. Unfortunately, it is a common mistake. Can I substitute envelope of function to phonetic testing here? So if I were to read, of all mistakes that can be made in restorative orthodontic treatment, or restorative or orthodontic treatment, restriction of the phonetic testing is one of the most problematic. Because phonetic testing is a form of envelope of function, right? Putting anterior teeth into relationship that restricts a more horizontal envelope of function, more horizontal phonetic testing as sound, is an almost certain cause of excessive wear, mobility, or forced movement of the anterior teeth. Unfortunately, it is a common mistake. That's exactly right. If I asked you, does phonetic testing represent some form of envelope of function? I think you have to say yes. Now, envelope of function will also include your mascatory movement. So so phonetic testing is not the same thing as envelope of function. True. But phonetic testing does give you a smaller range of envelope of function. Just like envelope of function is smaller range than envelope of motion, envelope of phonetic testing is smaller range than envelope of function. So what I'm trying to say is, if you take this idea that envelope of function needs to be respected, not constricted by anterior guidance, then you need to extend that courtesy to phonetic testing. Okay? When you see the last sentence on that side, when you see excessive wear on the labial-lingual edge of the lower anterior teeth, or on the lingual surface of the upper anterior teeth, always look for restriction of the envelope of function as a potential cause. True, but how do you test that? I say phonetic testing. Because envelope of function is a conceptual idea. How do you actually test it in the mouth? Are you going to have them chew food? Okay. How are you going to mark the teeth? How are you going to visualize the teeth when they are chewing food with their lips closed? Again, I am trying to emphasize to you the importance of phonetic testing. Okay? What what phonetic testing doesn't catch all the time is what page 145 talks about, and that is lateral movement, lateral envelope of function, or lateral movement. Because most of the times, people, when they are talking, It's up and down and anteroposterior, anteroposterior. It's rarely lateral. Okay? Okay. So let's take a look at page 145 on the left-hand column, bottom, how the envelope of function is programmed. And this is actually, good point. Envelope of function to a certain extent is programmed because of habit, because of the brain trying to avoid interference, and so forth. Think of it like this. When our jaw is moving, it's a skeletal movement, right? Our jaw movement is a skeletal movement. Now, if my hand is also a skeletal movement, most of the times when my hand is doing something, my eyes coordinate with my hand. So if I pick up my pointer, right, when I went to reach for it, I looked at it and I grabbed it. Now, based on if I was a blind person or if I became momentarily blind, I looked at where my mouse was, my pointer was, but for some reason I couldn't look at it anymore. I turned this way. Hopefully you can see me. Now I have a three-dimensional muscle memory in my body as to where that pointer should be. And when I reached out, I got it. It wasn't as accurate as when I was looking at it, but I got it. It was close enough. Now, our jaw, lower jaw moving, even though it's a skeletal movement, there is no visual secondary confirmation, right? Because we can't see how our lower jaw is moving. Guess what that confirmation is? That's your teeth contacting. And that is the anterior guidance. Anterior guidance is my fingertip telling me I'm touching my laptop. I'm touching my desktop. I'm touching my cell phone. My perceptive ability is that. That's all it is. And it tells my brain, and then when I'm grabbing my cell phone, I know what to expect. I'm not gonna grab a knife the same way I grab my cell phone. So so when all these people tell you that somehow anterior guidance is the golden key to your occlusal therapy to your patients, I want you to keep in mind there is nothing special about anterior guidance. It has to be as as Dawson says, it has to be in harmony. Okay, it has to be in harmony. Okay. Now, so how does my teeth feel? Remember I told you anterior teeth have a lot more neural proprioceptors than the posterior teeth. So the posterior teeth cannot feel as much. Okay? He doesn't explicitly talk about that, but on page 145, okay, on 145, on the right-hand side, okay, I'm going to start reading on the second paragraph. The criteria for reflex responses in the musculature typically relate to the stimuli that are fairly constant in their application, but modulation of motor responses, including jaw reflex movements, may be produced by periodontal pressor receptors, mechanoreceptors in the mucosa the pain fibers, and muscle spindle afferents. One thing appears clear, certain. The repetitious movements of the mandible that determine the envelope of function are far more complex and far more influenced by exquisitely sensitive sensory system that can be explained by simplistic explanations. Okay? Um, but clinical observation is too consistent to be ignored. And then the next paragraph, it goes, it has generally been accepted that horizontal and lateral vertical pressure sensation is generated entirely from pressure and tension sensors located in the periodontal ligament. So the PDL proprioceptors is what gives the feedback, a lot of feedback how the teeth contact. And that in turn gives a reflex. So that actually reminds me of a concept that I wanted to share with you. And you know that many times people will say, we sort of talked about it, anterior jig. If you in an NTI splint, those like try to prevent people from biting hard by having the front teeth touch first, you know, and then because they can't clench, we think that helps them with the TMJ problems or muscle pain problems, only to find out after a few days that benefit goes away, especially if they sleep with it. Okay. What I wanted to tell you is this. Literature is pretty congruent, firm on that if you take away the back teeth from contacting, only front teeth to touch. Okay, when somebody bites down, only front teeth are touching, that their mascatory force gets reduced. They cannot generate as much force biting with the front teeth versus the back teeth. So then many people said, well, if the problem is patients are clenching too much, we just need to make sure only their front teeth are touching so they cannot clench too much. That's the idea about Lucius jig and NTI for treating muscle pain patients, clenchers. But there is a major flaw to that thinking. What if the reason why patients cannot generate a lot of biting force if the only front teeth are touching is because that's a reflex. That's kind of like if my if my if my fingertip was touching a knife, I feel the sharp. Does my fingertip want to keep on pushing it hard? No. My fingertip says, that's enough to touch. I don't want to go anymore. It's a reflex. If I have a thick part of the knife, I can go and press all I want, and it doesn't hurt me. And this is where I think it's major confusion in dentistry, because we're getting into that, and I've said this many times to you before. By overemphasizing anterior guidance, and then to couple that with the research that if only front teeth touch, people cannot clench, dentists are brainwashed into giving everybody strong anterior contact, and that's all they care for. They don't pay attention to the posterior. But in fact, what we need to do is to create healthy posterior stop that is safe for them to clench without damaging the teeth. That's what we need to focus on instead of preventing them from clenching. Okay? And I think just breaking away from not insisting on anterior guidance on every case is the starting point of that. Because when you're anterior contact is too strong, that's almost always a, prevention for adequate posterior support. Posterior support needs to occur in CR and in CO, maximal inner cuspation. Okay? So when you are thinking through this, all these concepts that we've talked about so far, okay, we come to the conclusion that the muscle needs to, the needs of the muscle need to be satisfied. And we cannot do that by first satisfying anterior guidance. Okay? And it's not a coincidence, and this I give credit to Dawson. He talks about all these before we talk about smile design and anterior guidance, anterior relationship. Okay? You have to understand this first before we talk about how teeth should look. Because if you don't understand all this stuff that we talked about for last, I don't know, uh, wow, today is the sixth session, right? Half a year. Before we talk about all this, before we get to the teeth, we have to have understood the role of the bone and the joint and the muscle. Now we are ready to think about how the teeth should look. I hope your patients, you're satisfied with your patients, because now we can start talking about teeth, functional design of smile. Okay, and the first picture we see is the TMJ and the muscle anyway, in the book. But okay, but you know we need to understand that first. Okay, now we're into page chapter 16. Okay, we're getting there. So he says on page 151. Okay. Well, actually, before we get to that, let's talk about page 150. Decisions in smile design. Why? Because after all, most of us, when we talk about smiles and good looking teeth, we're talking about anterior teeth, whether it's upper or lower. Most of the times upper, but we're talking about anterior teeth. Yes. Okay. We're not talking about anterior guidance yet. We're just talking about anterior teeth shape. Okay. Now he talks about the importance of mounted cast and this, da, 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 da. And when you think about what he's going through about the rationale for mounted cast, and you look at the mounted cast and he recognizes that there is interference, he does the equilibration on the mounted cast on the model, and then he does the anterior wax up. Whether you do that on the cast or not, the, the reality is you need to recognize that's one way or the other is what needs to happen in the mouth. Meaning, if you have posterior interference, good luck with doing anterior work. Now, I'm not suggesting everybody needs to be equilibrated, but you need to be comfortable that their CR is fairly stable. If you recognize their CR is not stable or they don't have adequate posterior support, and all you want to do is to slap on veneers, you deserve to get all those things break, and you're going to have problems. That's the lesson we need to learn for Dawson going through this exercise. Don't look at it and say, "Oh, I'm not going to spend time doing diagnostic cast and this and that, da, 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 da." Okay? I'll be honest with you. Do I do that in my practice right now after, I've been practicing dentistry for, oh gosh, 35 years? No, I don't. But I always check my occlusion. I check my phonetics. I check my posterior stop. I check for my excursives before I answer my patient's question about veneers or anterior implants. Okay? So we don't have to follow everything Dawson is doing. I realize our everyday practice does not give us the luxury of doing this mounted cast and all that. Okay, I understand that. But in your head, you need to know how to compensate for not doing that and not forgetting the principles involved in doing these things. Okay, because and you don't even need to have any TMJ problem. If you have interference in the back, that is sure bet. Guess what though? If you have interference in the back, what ends up happening? Most of the times, those are the people who have excessive accelerated wear and tear on their dentition. So you want to do your smile makeover on those people who had worn away their teeth? You have to think about why do they wear away their teeth like that? Because just like they wore away their teeth, they're going to break my veneers. They're going to break my implant restorations. Okay? Now, it's interesting how he has that drawing in page 157. He gives you these various planes of the upper incisor. And he points out number one as not incisal edge or facial, but where it touches the lower teeth, supposedly. Okay? And he gives you that angulation on page 13-3. You know, the way I look at it is like this. That they talk about we want our front teeth to touch. And I don't want to offend them, so I'll say, okay, class 1 occlusion, they can touch. The problem is, when do I want them to touch? They're going to say, I want all of them to touch at the same time as posterior. Well, but the posterior teeth and the anterior teeth, they all have ligaments. PDL, when do I want them to touch? The PDL dimensions may be a little different, front to back, so forth. So if you're true class 1, I'm going to tell you, and minimal anterior movements, you want your front teeth to touch after you have bottomed out posterior ligaments, posterior PDL. Almost like you've been taught to bottom out the teeth, the adjacent teeth before you have your implant contact. Okay, so anterior teeth should not be initial contact point. Anterior contact point should not lead to fremitus. Anterior contact point should not lead to shiny occlusal stops. Okay, while it's still satisfying phonetic testing, by the way. Okay, so I think that's the most important aspect, okay, of this anterior relationship. And I have never heard of anybody who defines how much anterior teeth should contact, okay, in an anterior guidance, this or that. Anterior guidance is anterior interference if it causes fremitus. That's not guidance, it's trauma. Okay, so remember that. Now, the interesting thing is maybe I missed it, but we sort of have this, we all know, we all have this idea about what anterior guidance is, right? So he has the chapter 17. He says anterior guidance and its relationship to smile design. But tell me if I missed it. I don't see actual definition of anterior guidance. You know, and if you think about it, conceptually he tried to define the video. We try to define CR. Those are all important concepts. Anterior guidance is an important concept. Okay. In page 160, very first sentence, indeed, he says, next to centric relation, the anterior guidance is the most important determinant that must be made when one is restoring an occlusion. Second paragraph, the anterior guidance has similar importance in orthodontic treatment. Third paragraph, besides being the most visible part of the smile, the relationship of the anterior teeth in function is the principal determinant of posterior occlusal form. The next paragraph, the contour and position of upper and lower anterior teeth are so critical that an error in less than a millimeter in incisal edge location can feel grotesque to some patients. I agree. But I swear, I can't find what anterior guidance is in defined sentence. There is no definition of anterior guidance. I don't know. If you find it, if you think I missed it, please point it out to me. Feel free. You know, right? I can't find it. I went back and forth. They talk about it all day. Okay? But I can't find it. The closest thing that I get is page 175. The little box at the bottom. The key point. For optimal stability, comfort, and function, the anterior teeth must be, so I'm assuming that's the satisfying anterior guidance, in harmony with neutral zone, in harmony with the lip, in harmony with phonetics, in harmony with centric relation, in harmony with the envelope of function. I'm going to say, okay, that's the definition of anterior guidance. Where does it say anything about contacting teeth? Okay. I guess the bottom sentence. This results in tooth position and contour that are in harmony with a matrix of functional anatomy that also produces the most natural aesthetics. I have no problem with any of this. All I'm saying is, so what's that got to do with this dogmatic anterior guidance that I have heard 10 million times? That's why I'm telling as long as those of you who have known me, you have heard me say over and over, anterior guidance is overrated. Anterior guidance is overrated. Let Dawson speak for himself. Okay? This is why I use this book. You know, they have the entire chapter named after anterior guidance, but they don't define it. They don't tell me how it's going to work. Okay? So don't feel so bad. Or hopefully don't have too much pity for me when I speak so much against overselling of anterior guidance. At the end of the day, it is indeed the harmony. It is not canine touching that overrides everything else. Okay? And sooner you learn to incorporate this idea into your daily practice, okay? You will have an easier time. A typical example would be, and we do this all the time. Patient comes in, has a chip on number 8. I'm going to do composite on it. Am I going to worry about anterior guidance in tooth number 8? No. I'm going to make sure number 7 touches, number 9 touches, but my composite's not going to touch. Right? Okay. I think it's very helpful. We came to this page before, so I'm gonna just kind of go over with you here. You know, um, let's take a look at this here. Figure 12-7. Different anterior guidance pattern represent variations of inclination of the upper anterior teeth. Yes, so all those movements, right? So he's saying movement is what matters. But you know what? You know what throws you off? Is picture like figure 17-1, where they tell you centric stop and all the front teeth touching at the same time. If they're touching like that all the same time in the front, in the envelope, the front teeth will touch more. That's what you have to recognize. Because our mandible has lateral component in our movements, it needs to have a built-in long centric anterior freedom in occlusion. And if you allow that, that means your front teeth cannot touch at the same time as your posterior teeth touch. That is why drawing like figure 17-1 does more harm to dentists' understanding. People just memorize that and they repeat it like a parrot. They should touch at the same time. Okay? Mari.
Sir, I think that what most people miss is long
Yeah.
centric. They don't allow enough space
Mhm.
for the people to move a little bit of lower arch and to clench.
Yes, exactly. So you can describe it any which way you want. Long centric, wide centric, envelope of function, phonetic testing, make sure there is no fremitus. They all speak to the same thing. And ultimately, this idea about anterior guidance is pretty slippery slope. That's why they can't define it. Okay? Because by the time you define it, it's not a big deal. Okay? Okay. So now, I will say this. The drawing in page 162, the bottom picture, you know how he talks about the front teeth having that anterior stop? I will say this. If I do not have adequate posterior support and somehow I need to rely on my front teeth touching, there are occasionally cases like that. Let's talk about all on 4. If I have an all on 4 in maxilla, I want my lingual contour of my front teeth to touch my lower teeth because I don't have adequate posterior teeth, number of posterior teeth. So if I'm going to set that up, I want my anterior teeth to contact, but not like that picture in Dawson's picture. I'm gonna say, I don't know. Would you agree that that's somewhere around 45 degrees contacting between upper and lower? Okay, the angulation. If I want my front teeth to touch because I don't have adequate posterior teeth contact, okay, even though that's not ideal, sometimes I will go for that. In that case, as well, I want my upper and the lower to touch like this, even in the front. How do I do that? I want my upper incisor to become more like a chair, not gradual like this, like an S curve, like Dawson drew it. It should actually be more like a flat. It's like a chair, okay? Like an L shape. So that if they are touching, the lower incisor is touching the upper at a axial loading, not lateral loading. And then when they touch like this, and then give that room, lateral anterior room, so that it's not moving the upper front teeth sideways. Please remember this. This can be helpful for you at some point. 99% of times, I don't want my front teeth to touch, but occasionally I want them to touch if I feel that I don't have adequate posterior teeth. And in that such situation, I will make them touch in just like the posterior, axial loading to flat stop, not an angle. So it does not look natural. Yes, it does not look natural. I have never had a patient who complained to me that it does not look natural because they don't have any concept. They can't look at it. Lingual of the maxillary anterior, they can't look at it. Okay, so as long as it's functional, then that's fine. Okay, so I hope you can see the logic of that. Okay, and then when we are looking through the rest of the chapter, okay. I think in a figure 17-4, we're trying to now determine anterior anterior facial wall, facial plane, right? Okay. What he's saying is that how we look at incisal edge, okay, is also affecting how the incisal plane or the facial plane is gonna be on the teeth, right? So, so decision one, he talks about decision two, decision three, and all that. Decision one is where they were gonna touch on the lingual. Okay. Decision two is the facial plane. Is the facial plane having adequate lip support? Or does it look like a buck teeth when the patient smiles? Okay. And then decision three, do you want the incisal plane, incisal edge or the facial plane to have a retroclining look or a proclining look? Okay. Almost all of you think of the facial plane as one plane. No, it's actually minimum two, if not three planes. And your prep has to accommodate that sometimes. Most people, incisal prep, inside like maxillary anterior or lower anterior prep, is just straight up and down facial. No, it needs to have some curvature to it in order to accommodate this plane, the different plane, whether it's, especially if you want them to look slightly retroclined. Okay. And then um, 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 uh, decision four, and that's gonna be what? That's going to be determined by phonetically with your F sound, F, F, F. And then S, S, S. Where you place that number 4 has to satisfy your phonetics. Okay? Now 2 and 3 should be satisfied by looking at the smile. Okay, I think the best picture for that, I thought I saw, yeah, something like, let me see, page 166, picture, figure 17-6A. Okay, so, we have a block of acrylic there. Okay, so what I'm going to do if I have a block of acrylic like that in the mouth is first, I'm going to alternate back and forth. I'm going to do phonetic testing and I'm going to check the occlusal contact. I want to do phonetic testing to get an idea if I can bring the acrylic forward a little bit more, facial plane, while I'm carving out on the lingual to give room for the lower incisor. And then if that, the patient is not smiling here, but if the patient is smiling, you want that acrylic in your provisionals to match, follow the contour of the lower lip, just like figure 17-7. Okay. Ultimately, you want that to be carried over to the opposite page, page 167, figure 17-9, 17-10. Your incisal plane, incisal edge plane needs to more or less follow your lip contour of the lower. And that's what most of us think of it as aesthetic smile. But you have to think about the facial plane, facial plane, how much you want to stick out and back, okay? You need to look at that. And don't forget how F sound will help you determine that, okay? Now, decision number 5 is anterior freedom, lower anterior freedom, okay? So, now, he talks about now he made a comment here that I thought was a little troubling. So I'm gonna just make sure I go over with you on this so that his intention is, I think, explained to you well in case if you got hung up. On the last sentence on page 168 on the left-hand column, before he says the 5 steps to harmony. So about halfway down, the paragraph there, he says, any reduction of posterior support is helpful because the fewer posterior teeth that contact, the easier and occlusal adjustment can be made, and the simpler it is to observe hypermobility patterns on the teeth that remain in contact. Because we're talking about primarily anterior teeth, that's um, I understand what he's saying. I think some of you might have worked with me when you were setting denture teeth. I said, when we are setting denture teeth in the front, I don't care to have any posterior teeth or even wax rim because they can get in the way. If you don't have the vertical dimension correct in the back, they're going to get in the way. So when I do my uh, teeth trying or wax rim of my dentures, I deliberately make my wax rim in the back much shorter. So there's no way that they're going to be in interference. So I can set my anterior teeth ideally where they need to be. And then I will provide posterior support in the back adequate so that the front teeth are not traumatized. Okay. But when it comes to working with the natural teeth, That's not something you can do. You cannot arbitrarily just grind away the posterior in order for you to work on the front. No, you can't do that. Okay. So I just wanted to make sure that sentence, when I would read it, I go like, what? So I kind of had to read it, what his intentions were. Okay. So don't get that confused. Okay. It is important that you need to make sure you have no posterior interference. Absolutely. Okay. But he doesn't describe it like that. He just talks about posterior contact. So I just wanted to just reemphasize to you what he's saying is posterior interference is going to get in the way. Okay. So for example, when he's talking about, when you're looking at his teeth here, the example of the anterior establishing of the anteriors. It's interesting how he's showing you these things here, and this is where I have, you can do it this way, and why he's saying that, and then he goes on to take a look at that figure 17-11. Centric relation stops marked in red. He's talking about anterior. But you notice how the posteriors are prepped? Okay. So the posteriors don't get in the way. Right. I understand that. But I want you to keep in mind, you cannot have anterior stop like that established just by itself in true function. That's why it's somewhat misleading, because you need to have the posterior stop. Because if the anteriors are truly the only stop you have here, those markings that you have, they are not this chair stop markings like I told you. They're still at an angle, a little bit like that. So that's not going to be vertical stop. Your front teeth are going to get traumatized in that sense. Only way you can avoid that is if you have posterior provisionals or posterior restorations, okay, so that the front teeth are not truly the vertical stop. You don't want to have vertical stop occurring in anterior teeth. Okay? If you are going to have that during certain treatment phase because you're waiting for certain things to heal and things like that, I can understand that. Okay? But you do not want to aim for anterior stop as being a constant, definitive feature of anybody's occlusion. Okay? Okay. If you go through this step by step, you know, um, I think it's helpful, but to be honest with you, I think it's quite confusing. Okay. So step one, it says establish coordinated centric relation stops on all anterior teeth. Okay, let's just kind of follow through on that. We have no posterior teeth. Step two, so you got to do occlusal equilibration so they're all touching at the same time. Step two, extend centric stops forward at the same vertical dimension to include light closure from the postural rest position. So what he's saying is go ahead and give anterior freedom. Okay? All right? But without the posterior, how do you, it's so arbitrary how they're going to move forward. Okay? And I think it's really more of a vertical movement than anterior movement. Okay? And then they say determine the incisal edge position. Okay? So let's just kind of read that because that's important. Because the first step and second step, I'm going to just tell you, I would don't lose the posterior support. Sort of to counter what he's saying. But when it comes to determining incisal edge position, he says location of the incisal edge is second in importance only to centric relation holding context. If the anterior teeth are stable and no contour changes are needed, the incisal edge position should be maintained. If the incisal edges are to be altered restoratively, the changes should always be determined in provisional restoration first and then copied in final form only after the patient has approved the comfort and appearance. So, I want you to know provisional is really used for not only comfort and appearance, but what does that mean? It means it has to satisfy your range of motion, range of function rather, phonetics. Your provisional has to satisfy your phonetics. Only then is it worth anything for you to communicate to the lab. Okay? Upper front teeth, you need to, once you prep and once you provisionalize your impression and provisionalize, okay? Oftentimes, okay, especially if it's more than one unit, you need to make sure in excursives and so forth, phonetics, I mean, not only phonetics, but in clenching, there is no fremitus, no mobility. And then you need to communicate that to the lab. Because if it's one tooth, like I said earlier, I just need to make sure it doesn't touch. It looks good, but it doesn't touch. But if it's starting to be two or more, they may have to touch, especially in excursives. And the question is, how much do I want them to touch? Okay. And that can only be replicated by the lab if you give them something in the form of provisional. Okay. Now, then he talks about establish ideal anterior stress distribution and lateral excursion. So basically, what he wants is anterior guidance as a group function in the anterior. Okay, and that's all fine. Okay, I don't have any problem with that. But I want to emphasize again: don't be doing all that. I mean, even if you did all that without the posterior, make sure you give posterior final restoration that provides adequate support for the front so that the front teeth are not being the first initial contact point. Okay. So he talks about, you know, communicating details to the technician. Yes, we have to be able to do that. And oftentimes, your provisional has to be good enough so that the lab can follow you. You cannot expect the lab to be able to mount it, not even on a real articulator, just snake bite, and know how to satisfy all these things when they're giving you the lab result. I mean, the finished product. Okay? So keep that in mind. Okay? And one last thing I think is take a look at picture 17-16. I know not all of you had a chance to see me use that diamond disc for working up anterior aesthetics. That is something that you need to be able to do if you're going to be doing anterior aesthetics for your provisional. I encourage you to do that, practice that. Okay. Not only get the, excuse me, not only get the facial contour, embrasure space. Okay. A lot of times incisal edge, mesial line angle, distal line angle is best if you work it out with the disc. Okay. But really, going back to the key point, page 175, I really hope that you can remember what Dawson's key points are after he talks about the entire page of anterior guidance. And he's not talking about teeth. Okay. I'm gonna say we're gonna stop here. I am getting quite tired. And this stopping here will give us a good opportunity for us to review some of these before we go to our next progression. Okay. So I am marking my book for this. And then I know you're disappointed we didn't get to 198. I'm gonna ask you to read next chapter for next month up to page 232, posterior occlusion. So we're gonna have an opportunity to talk about anterior teeth and posterior teeth. We're talking about teeth. All right, next time. Okay. Do you have any questions? Let me see. No. Okay, the text came in from other people, not you. Okay. So if you do not have any questions, I hope that means that I was incredibly clear. Ha ha ha. Right. So our next meeting is, just to confirm, May 17, the Sunday after Mother's Day for all of you who are mothers. Okay. You know, I schedule my things around Mother's Day. So for as a respect for that, okay. So it's a good number of weeks, so you can have a little brain cooling period before you start warming it up again reading. And I will have the recording up within a week or two, and so that we can have other people who were not here be able to get caught up. All right. Sounds good, everybody? Enjoy the spring. I mean, we live in a crazy world, so it's probably not a bad idea for us to study dentistry rather than look at the rest of the world. Okay. Okay, everybody. Thank you so much for joining.
Thank you.
Okay. Have a good rest of the day. Thank you.
Thank you, Dr.
Thanks,
Lee.
Dr. Lee.
Okay. Bye-bye.
Bye.
Thank you.